இன்னைக்கு அமைதியான நதியினிலே ஓடம்.
நீங்க அத ஆரம்பிச்சு கொடுக்க பாடுவார், தொடர்ந்து பாடுவார். நல்ல பாட்டு.
திரு டைம் பாத்துட்டீங்களா? திரு டைம்
பாத்துட்டு சார் 3 more minutes சார்.
வாங்க ஜனனி. குட் ஈவினிங் ஜனனி. வணக்கம் ஜனனி. வணக்கம் ஜனனி.
வணக்கம் சார்.
Yeah, Janani is not bad. With all grandchild, she is able to attend. Thank you, Janani.
Sir, Pierre sir, vanakkam sir.
Good evening.
Good evening,
Pierre sir, vanakkam.
PRC sir, vanakkam.
Good evening, sir. PRC sir, good evening.
Good evening, all of you, sir.
Good evening, Janani madam. Good evening.
Nandini ma'am, Srinivasan sir, Tangavelu sir, PRC
vanakkam
sir.
vanakkam ellarukkum.
Sir, Rajendran.
Satish sir, hello sir.
Vanakkam President Ramesh.
Good evening sir. Good evening.
Vanakkam President.
Good evening, Ramesh Babu.
President Ramesh madam. Good evening. Good evening.
Good evening.
Good evening.
Rajendran varla.
Good evening all. Good evening faculties. Good evening.
Sir, PRC sir, Zoom கதவு திறந்துட்டீங்களா?
3 minutes ஆரம்பிச்சாச்சு. திரும்ப 3 minutes முடிஞ்சாச்சு.
2 more minutes sir. 2 more minutes. கரெக்ட்டா ஷார்ப்பா 8 o'clock ஆரம்பிச்சு.
All the best for the program.
Yes sir, good
evening. Long time no see.
Thank you sir.
It's 8 o'clock.
Sir, Thangavel sir, rehearsal already பாத்துட்டீங்களா?
பாத்துட்டோம். 3 to 4 பாத்துட்டோம். ஆமா ஆமா. நாங்க என்ன சிவாஜி கணேசன் ரிஹர்சலே இல்லாம நடிக்கிறதுக்கு.
He is always very
ஒவ்வொரு வாரமும் உங்களுக்கு வந்து ஒவ்வொரு மந்த் வந்து உங்களுக்கு வந்து டபுள் வேலை.
இல்ல நாங்க இல்ல சரியான தலைவரை எடுத்துட்டோம்ல. இன்னைக்கு ஒரு தலைவி.
He accepts everything, all responsibilities with a smile.
இல்ல நந்தினி தலைவி இந்த வாரம், இந்த மாதம். ஒவ்வொரு மாதம் ஒரு தலைவரே
வந்து ரொம்ப டஃப்பான வர்க். மந்த்லி வந்து உங்களுக்கு இதுவே வந்து நீங்க கோஆர்டினேட் பண்ணி பண்றது.
நந்தினி தலைவியை ஏத்துக்கிறதுக்கு நீங்க நந்தினி கொடுத்து வச்சிருக்கணும்
சார். நான் நிறைய கோஆர்டினேட் பண்ணேன்.
வணக்கம்
அமல்ராஜ். வணக்கம்
அமல்ராஜ். குட் ஈவினிங். உங்களுக்கு
குட் ஈவினிங்.
சுனில் வணக்கம். வணக்கம் சுனில்.
குட் ஈவினிங் டாக்டர் அமல்ராஜ்.
Good evening, madam. Nandini, madam. Good evening. Satish sir. Good evening, sir. Guru sir. Good evening.
வணக்கம் அமல். வணக்கம்.
பாலாஜி, சுனில்.
அமல் புன்னகை ரொம்ப சந்தோஷமா இருக்கு. எங்களுக்கு மனசுல ஒரு மகிழ்ச்சியை ஏற்படுத்துகிறது.
Thanks sir.
திருமுருகன் ராஜேந்திரன் சார் ஜாயின் பண்ணலையா?
அவர் டிராபிக்ல மாட்டிட்டு இருக்காரு சார். ஃபோன்
நம்ம ஸ்டார்ட் பண்ண சொல்லிட்டாரா?
நம்ம ஆரம்பிச்சலாம் சார் 8 o'clock கரெக்ட்டா.
ஓகே 8:01 ஆயிடுச்சு.
நீங்க இருக்கீங்க. அண்ணாமலை சார் இருக்காரு, கோபால் சார் இருக்காரு.
ஆரம்பிச்சிருங்க. திரு 8:01 ஆயிடுச்சு.
8 o'clock சார். 8 o'clock ஆரம்பிச்சிடலாம் சார்.
வணக்கம் சுனில்.
Thank you.
சுனில் இருக்காரு, பழைய பிரசிடென்ட், நிறைய பேர் இருக்கீங்க. ஆரம்பிச்சிடலாம்.
திருமுருகன் ஸ்டார்ட் பண்ணுங்க.
Yes sir. Good evening everybody. It's a great pleasure to be here to welcome you all for this monthly update for practical pediatricians. Today we are going to talk about a very important aspect which essentially decides our livelihood, and that is the medico-legal issues. Given that now we have got more patients who are chasing the court, and there are more lawyers who are chasing them, I think we have to be extremely careful in making sure that we don't fall on the wrong side of the law. So for that we have got a galaxy of stars over here. I mean, as usual, our convener Tangavelu sir, who has been instrumental in putting a great team. So before we move on to that, may I request our President Ramesh Babu sir to say a few words and start the program off. Thank you sir.
Thank you Dr. Tirumurugan sir. Good evening to all. Respected President 2021 Dr. Ismail, respected President-elect Dr. Suresh Balan sir, respected Dynamic Secretary of IAPT NSC, Dr. Rajendran sir, respected Treasurer Dr. Gopal Subramaniam sir, and the convener of the updates for practicing pediatricians, respected Professor Dr. Thangavel sir, and the chairperson of today's event on medico-legal issues, Nandini Kumaran madam, and the respected faculties of today's event, Dr. Thangamuthu sir from Pollachi, and Dr. Subramanian sir, Dr. Satish sir, and Dr. Sudarsana madam. It's a pleasure to welcome you all for this event by IAP TNSC. I welcome the office bearers of IAP TNSC, the Central IAP members and Central IAP office bearers, and the delegates who are participating through Zoom as well as through IAP TNSC YouTube channel. It's a different topic on the medical legal issues. It was the idea was given by our convener Thangavel sir, so that each and every pediatrician IAP member should be aware of the happenings and the legal aspects, which will help them to avoid consequences arising due to legal things. So at this outset, I won't take much of time. It's over to Tirumurugan sir to introduce the speakers and faculty.
Gopal for prayer. Gopal for.
Yes, sir. Gopal sir. Actually, my apologies. I missed the talk.
Anyway,
Should have started. So Gopal sir.
We can have the prayer now, pediatricians prayer. Then we can proceed.
Okay. குழந்தை மருத்துவ எங்களுக்கு முழுமையான குணமளிக்கும் திறனை தாரும், நோயரின் துன்பத்திற்கும் திறன் நமக்கு வழங்கப்பட்டது எப்படிப்பட்ட சிறப்புரிமை என்பதை பணிவுடன் நாம் உணர்வோமாக. எல்லா குழந்தைகளுக்கும் அவர்களின் குடும்பத்தினருக்கும் அவர்களின் சமுதாயப்படுதலை மற்றும் சாதிமர பிரிவுகளை பாராமல் நலம், கற்றல், ஈகை, அன்பு, அமைதி ஆகியவற்றின் தூதர்களாக என்றும் இருப்போமாக. நம்மால் முடிந்தவற்றை மாற்றவும் நல்லவற்றை உள்வாங்கவும் மாற்ற முடியாத காரணத்துடன் ஏற்றுக்கொள்ளவும் போதுமான மெய்யறிவும் பொறுதலும் எங்களுக்கு வழங்குக. உங்களது வாழ்த்துக்களையும் அருளையும் கருளையும் எல்லா சூழல்களிலும் நேரங்களிலும் அனைத்து மக்களையும் கொடுத்து அருளுங்கள். நன்றி. தேங்க்யூ திரு.
Thank you, sir. Thank you, sir. So
Gopal,
may I request now,
with the permission of the prayer, Yamalada David. Save us from medical legal case also. Tamil Padthi. An important prayer.
Thank you, sir. So may I now request our Vice President Annamlai sir to say a few words.
Respected President Dr. Ramesh Babu sir, Dr. K. Rajendran Secretary, Dr. Gopal Treasurer, the President 2021 Dr. Ismail, President-elect Dr. Suresh Balan, Dr. J. Balasubramanian Joint Secretary, the Convener Dr. S. Thangavelu sir, Chairperson Dr. Nandini, and the speakers Dr. K. Thangamuthu, Dr. A. Subramaniam, Dr. C. Satish sir, Dr. Sudarshana Skanda. I welcome you all for this important update for practicing pediatricians, medico-legal issues. And I'm sure that many of the practitioners and all the pediatricians will be eagerly waiting to know about the issues currently being faced by most of the pediatricians and all the other branch doctors also. So without wasting much time, I thank the organizers for this opportunity and I welcome all the speakers for this update for the practicing pediatricians. Over to our convener, Dr. S. Thangavelu sir.
மறுபிற்குரிய தங்கமுத்து சார் அவர்களுக்கும் சார் சீனிவாசன் சார், சேர்பர்சன் நந்தினி குமரன் மற்ற அனைத்து நண்பர்களுக்கும் வணக்கம். Why this medical legal issue was chosen? What I just had a retrospection. Before 1975, we have not encountered, I think. Between 1975 to 2000 started erupting. So far, we are only dealing with medical cases. Then medical legal started appearing from 2000 onwards. Now there is an intense threat to the medical profession from the medical issues. So what are all the reasons? Probably I'll take only 2-3 minutes. One is the media played a major role. Every case of death or big disability or every case, health case scenario was converted from medical to legal. Mainly the role of media and other professions also played a role. Second is role of money. Earlier, the treatment cost was not so enormous. Now, if a child is admitted in ICU with some sick problem, child recovers, of course, because of ICU, but they have to spend almost 1 year salary. If you imagine a middle income group person salary is 50,000 rupees, he will spend around 5 to 6 lakhs. Whole 1 year salary is spent on health cost. That is another important reason. Third is a lot of healthcare providers involved in the management process. Earlier, one doctor, family doctor, one child, parents and family. That's all. Very simple. They had a full faith on either side. Family believed the doctor, doctor believed the family. Now, a lot of people, a general pediatrician refers, received by a ER medical officer, then go to ward, another medical officer, then pediatrician, call for a specialist, imaging, surgery, so many things involved. Most of the time, all the doctors do not stay at one time to talk to the parents. Everybody talk differently to the pediatric, to the family, and then everybody get a different versions of the case. Lastly, the Thidum Nandrum Peradharavara. Main problem is within ourselves. We have changed a lot, both on better side and worse side. That's also a very important reason. Counseling has to be done effectively. One is true counseling. If at all it's a real problem, we have to explain to them even the real problem, that we can't save the limb, we can't save the child. All that has to be told to the parents so that they are prepared for the worst. Second is always we should have a joint counsel. Not every day, at least the child stays for more than a week, 2-3 days. All the doctors involved in the counseling treatment has to sit in a room, and it should be a joint counseling so that patient doesn't have any misinterpretation. I thought these are the few things which will prevent medical issues. The medical issues appear, what is going to happen is, that's what the faculty is going to talk. So I hand over the mic to Dr. Nandini Kumaran, chairperson, to conduct the proceedings. Thank you very much.
Good evening, one and all. I first initially thank the TNSC for giving me this opportunity, and our convener, Dr. Thangavelu. And today on the pediatric update on medico-legal issues, as Dr. Thangavelu said, we medical practitioners or pediatricians, life is a smooth sailing most of the times. But however, when a child treated with us, either in office or as inpatient, comes to us with medico-legal issues, then the smooth sailing, the Amediyana Nadi delay Odam, and becomes a turbulent tsunami for us. Whenever the medico-legal issues come up, it is only our organized and ethical professional work, that is a proper detailed history, proper recording and documentation of facts, proper counseling, as Dr. Thangavelu sir said, not only get the parents, whoever wants to come for counseling, give a proper counseling, and we have to have a good medical knowledge and a good presence of mind in dealing with medico-legal issues as and when it occurs. All this will help us to tide over the crisis. And we also have experts like Dr. Thangamuthu holding a very important position as in the legal committee of the IMA, PPLSSS. And this is how we can come out of the crisis when it happens. And today we have in the stage various experts who, with their real good knowledge on the medico-legal issues, with their vast and rich experience, are going to enrich us with this knowledge too. Initially, I would start off with
Nandini, 1 minute. Nandini, can you give me 1 minute? Sorry, I failed to introduce you. Just a few words about Dr. Nandini Kumaran. There are a lot of people who are teachers outside the teaching institutions with clarity of expression, analytic ability, and interesting teaching interest. All this are seen in a few doctors outside our teaching institution. But Nandini Kumaran is one among them. I have many times I have admired her way of the talk during the CMEs. She is in practice for the last 36 years, past president of IAP Coimbatore, national winner of IAP Practicing Pediatricians quiz in 2001, received Tamil Nadu State IAP Active Pediatricians Award, IMA Lifetime Achievement Award in 2018, IMA Academic Excellence Award in 2021. Now, sorry to interrupt, it's over to Dr. Nandini to conduct the proceedings. Thank you, Dr.
Thank you, sir. Thank you. Our first topic would be by Dr. Thangamuthu. Dr. Thangamuthu is a senior general surgeon from Pollachi, and he has had government service for nearly 21 years. He's held various positions in the Indian Medical Association, and his CV says that he has got the Best Doctor Award 3 times. One from the MGR University in 2012, one from the Indian Medical Association of Tamil Nadu, and one from the government of Tamil Nadu. And now he is holding a member of the legal committee of the state branch of Indian Medical Association for the last 10 years. And sir has replied almost 1,500 lawyer notices as the legal committee chairperson, and about 60% of the cases he has won so far. So currently he's been the chairman of the PPLSSS of Indian Medical Association of Tamil Nadu, and he is the apt person to start off our session with medico-legal issues for pediatrician. Over to Thangamuthu, sir.
Thank you, madam. தமிழ்நாடு பீடியாட்ரிக் அசோசியேஷன் தலைவர் டாக்டர் ரமேஷ் பாபு அவர்களுக்கும், செயலாளர் ராஜேந்திரன் அவர்களுக்கும், ட்ரெஷரர் கோபால் அவர்களுக்கும், இந்த கருத்தரங்கை மிகவும் சிறப்பாக நடத்தி கொண்டிருக்கும் டாக்டர் தங்கவேல் அவர்களுக்கும், நந்தினி அவர்களுக்கும், இதிலே பங்கு கொள்ள வந்துள்ள டாக்டர் சுப்பிரமணியம், சதீஷ், சுதர்சன் போன்ற மருத்துவர்களுக்கும் மற்றும் இதை திரளாக கண்டு கொண்டிருக்கும் மருத்துவ நண்பர்களுக்கும் என் முதல் கண் வணக்கத்தை தெரிவித்துக் கொள்கிறேன். இந்திய மருத்துவ சங்கத்தின் முதலாக நம்முடைய தங்கவேல் சார் சொன்னாங்க, 2000ஆம் ஆண்டிலிருந்து தான் இந்த வழக்குகள் அதிகம் ஆகுதாக சொன்னாங்க. அது அப்படி இல்லை. முதலாக 1983ஆம் ஆண்டில் ஐக்கிய நாடுகளின் சபையிலே ஒரு தீர்மானம் கொண்டு வரப்பட்டது. 150 நாடுகளை கொண்ட அந்த ஐக்கிய நாடுகளின் சபையில் நம்ம இந்தியாவும் ஒரு அங்கம் என்பது உங்கள் அனைவருக்கும் தெரியும். அதில்தான் முதலாக நுகர்வோர் பாதுகாப்பு சட்டத்தை எல்லா நாடுகளும் உடனே அமுல்படுத்த வேண்டும் என கோரிக்கை வைக்கப்பட்டது அந்த செக்ரட்டரியால். அதை தொடர்ந்துதான் 1986ஆம் ஆண்டிலே அந்த சட்டம் நம் இந்தியாவிலே அமல்படுத்தப்பட்டது. அப்படி அமல்படுத்தப்பட்ட போது நம்முடைய மருத்துவத்துறை அந்த நுகர்வோர் பாதுகாப்பு சட்டத்தில் இருக்கிறதா இல்லையா என்பது பற்றி ஒரு தெளிவான கருத்து இல்லை. அது தொடர்பாகத்தான் IMA வர்சஸ் VP சாந்தா என்ற வழக்கு உச்சநீதிமன்றத்துக்கு சென்றது. அந்த உச்சநீதிமன்றத்தின் தீர்ப்புப்படிதான் மருத்துவத்துறையும் நுகர்வோர் பாதுகாப்பு சட்டத்தில் அடங்கும் என்ற ஒரு தீர்ப்பு வந்த பின்புதான் 1996ஆம் ஆண்டுக்கு பின்புதான் மருத்துவர்கள் மேல் நுகர்வோர் பாதுகாப்பு சட்டங்கள் நம்மை தாக்க தொடங்கின என்பதை இங்கு நான் குறிப்பிட விரும்புகிறேன். அதுவரை மருத்துவர்கள் மேல் நுகர்வோர் பாதுகாப்பு சட்டப்படியான எந்த வழக்குகளுமே இல்லாத நிலையில் அந்த சட்டம் மருத்துவர்களுக்கும் பொருந்தும் என்று 1996ஆம் ஆண்டில் சட்டம் நிறைவேற்றப்பட்ட பின்புதான் பல மருத்துவர்கள் மேல், குறிப்பாக மகப்பேறு மருத்துவர்கள் மேல் பல வழக்குகள் பதியப்பட்டன. குறிப்பாக மகப்பேறு மருத்துவர்கள், மிக சீனியர் மருத்துவர்கள் எல்லாம் பாதிக்கப்பட்ட போது டெல்லி போன்ற மாநகரில் உள்ள மகப்பேறு மருத்துவர்கள் தங்கள் மருத்துவ சேவையையே நிறுத்தி கொண்டார்கள் என்பதையும் இங்கே குறிப்பிட விரும்புகிறேன். இது போன்ற மகப்பேறு மருத்துவர்கள் மட்டுமல்லாது, இந்த நுகர்வோர் பாதுகாப்பு சட்டம் மட்டுமல்லாது, இந்த நுகர்வோர் பாதுகாப்பு சட்டத்தால் பல லட்சங்கள் கிடைக்கும் என்ற ஒரு கருத்து மக்களிடையே பரவத் தொடங்கியது. மருத்துவர்கள் பெறும் தோல்விகளை நஷ்டீடு வழங்கும்படி வழக்கு மன்றங்கள் கொடுக்கும் தீர்ப்புகளை நம்முடைய மீடியாக்கள் மிகவும் பிரபலப்படுத்தின. டிவிகளாகட்டும், பேப்பர்களாகட்டும், தலையங்கங்களாக எழுதின, தலைப்புச் செய்திகளாக போட்டன. இந்த விழிப்புணர்வு ஏற்பட்ட பின்புதான் மக்கள் நுகர்வோர் பாதுகாப்பு சட்டப்படியான வழக்குகளை வழக்கு மன்றங்களில் பெருவாரியாக தொடங்க ஆரம்பித்தார்கள் என்பதுதான் உண்மை. அந்த வழக்கு மன்றங்களில் சென்ற அந்த நம்முடைய நோயாளிகள் அதோடு நிற்கவில்லை, நம்மாலும் வழக்கு தொடர முடியும் என்ற நிலை உள்ளது என்பதை தெரிந்ததுமே கிரிமினல் வழக்குகளும், சிவில் வழக்குகளும், RTI நோட்டீஸ்களும், மத்திய மாநில மனித உரிமை கமிஷன் நோட்டீஸ்களும், நுகர்வோர் பாதுகாப்பு சட்ட அமைப்புகளான நோட்டீஸ்களையும், நோயாளிகள் நேரடியாக இந்த காம்பன்சேஷன் கிடைக்கும் நோட்டீஸ்களும், லோக் அதாலத் போன்றவற்றினால் நோட்டீஸ்களும் அதிக அளவில் மருத்துவர்களை வந்து அடைந்தன. மருத்துவர்கள் அதிக வேதனை அடைய வேண்டிய சூழ்நிலை ஏற்பட்டது. அது மட்டுமல்ல, கிரிமினல் சட்டப்படியான வழக்குகள் சிலவற்றிலே சில மருத்துவர்களுக்கு 2-3 ஆண்டுகள் கூட சிறை தண்டனை விதிக்கப்பட்டதுதான் கொடுமையிலும் கொடுமை. அப்படிப்பட்ட ஒரு நிலையில்தான் ஒரு வழக்கு உச்சநீதிமன்றத்திற்கு சென்றது. அந்த உச்சநீதிமன்றத்திலே 2004ஆம் ஆண்டு பதிவு செய்யப்பட்ட அந்த வழக்கு நம்முடைய கணம் RC லகோத்தி அவர்கள்தான் அந்த வழக்கை எடுத்து நடத்தினார். அவர் கொடுத்த தீர்ப்பிலே கிரிமினல் வழக்குகள் மருத்துவர்கள் மேல் போட வேண்டும் என்றால் கண்டிப்பாக ஒரு செகண்ட் ஒப்பீனியன், அதாவது எக்ஸ்பர்ட் ஒப்பீனியன் பெற வேண்டும். அதுவும் எந்த துறையைச் சேர்ந்த மருத்துவர் மேல் அந்த வழக்கு தொடரப்படுகிறதோ அந்த துறையைச் சேர்ந்த ஒரு மூத்த அரசு மருத்துவரிடமிருந்து கிரிமினல் வழக்கு போடும் அளவுக்கு அந்த மருத்துவர் குற்றம் புரிந்துள்ளாரா என்பதை உறுதிப்படுத்த ஒரு மருத்துவ சான்றிதழை பெற்று காட்டினால் மட்டுமே நீதிமன்றங்களோ காவல்துறையோ மற்ற கலெக்டர் போன்ற அதிகாரிகளோ அந்த மருத்துவர் மேல் நடவடிக்கை எடுக்க வேண்டும் என தெளிவாக ஒரு தீர்ப்பை 2005ஆம் ஆண்டு கனம் லக்கோத்தி அவர்கள் கொடுத்தார். அப்படி கொடுத்த அந்த தீர்ப்புக்கு பின்புதான் தமிழகத்தில் கிரிமினல் வழக்குகள் மருத்துவர்கள் மேல் தொடரப்படுவது குறைந்தது. இருந்தாலும் அந்த உச்சநீதிமன்றத்தின் தீர்ப்பு எவ்வளவு தூரம் வேலை செய்தது என்பதை குறிப்பிட வேண்டும் என்றால், கடந்த ஒரு 6-7 ஆண்டுகளுக்கு முன்பு இருந்தே உச்சநீதிமன்றம் கொடுத்த தீர்ப்புக்கு எதிராக தமிழகத்தில் 20-30 வழக்குகளுக்கு மேல் கிரிமினல் வழக்குகள் மருத்துவர்கள் மேல் தொடங்கப்பட்டன. அப்படி தொடங்கப்பட்டதை ஆட்சேபித்து இந்திய மருத்துவ சங்கத்தின் தமிழ் மாநிலங்களின் சார்பாக லீகல் சேர்மன் என்ற முறையிலே நம்முடைய உயர் நீதிமன்றத்தில் அந்த வழக்குகளை எல்லாம் எடுத்து காட்டி உச்சநீதிமன்றத்தின் தீர்ப்பையும் காட்டி, இது போன்ற ஒரு உச்சநீதிமன்ற தீர்ப்பு இருக்கும்போது எந்த ஒரு எக்ஸ்பர்ட் ஒப்பீனியனும் பெறாமல் இது போல வழக்குகளை தொடங்குவது சட்டத்திற்கு விரோதமானது, உடனடியாக தடுக்க வேண்டும் என 2017ஆம் ஆண்டு நான் ஹைகோர்ட்டில் வழக்கு தொடர்ந்தேன். நம்முடைய ஹைகோர்ட் அதை தீவிரமாக எடுத்து பரிசீலித்து அந்த உச்சநீதிமன்றத்தின் தீர்ப்பை யார் யார் காவல்துறை மீறினாலும் வேறு எந்த அதிகாரிகள் மீறினாலும் உடனே அரசு நடவடிக்கை எடுக்க வேண்டும் என ஒரு தீர்ப்பை வழங்கியது. அந்த தீர்ப்புக்கு பின் தமிழகத்தில் தற்போது மருத்துவர்கள் மேல் போடப்படும் கிரிமினல் வழக்குகள் குறைந்துள்ளது. அதற்காக நாம் உச்சநீதிமன்றத்தின் தலைமை நீதிபதியாக பதவியாற்றிய இந்த தீர்ப்பை வழங்கிய லகோத்தி அவர்களுக்கு கடமைப்பட்டுள்ளோம் என்பதையும் இங்கே குறிப்பிட விரும்புகிறேன். அத்துடன் இந்த 1998 நம்முடைய இந்திய மருத்துவ சங்கத்தின் தமிழ் மாநில கிளையிலே ஒரு PPLSS என்ற ஒரு அமைப்பை உருவாக்கினோம். ப்ரொஃபஷனல் ப்ரொடெக்ஷன் லோ சோசியல் செக்யூரிட்டி என்ற அந்த ஸ்கீமின் படி எந்தெந்த மருத்துவர்களுக்கு இது போன்ற சட்ட சிக்கல்கள் ஏற்படுகிறதோ அவர்களுக்கு உதவி செய்யும் விதமாக இந்த அமைப்பை உருவாக்கினோம். அந்த அமைப்பை உருவாக்கியதிலிருந்து 1998 உருவாக்கப்பட்ட அந்த அமைப்பிலே நான் 2007ஆம் ஆண்டு முதல் இந்த லீகல் கமிட்டி சேர்மனாக பொறுப்பேற்று கடந்த 15 வருடங்களாக என்னால் முடிந்த மட்டும் அனைத்து வழக்கறிஞர் நோட்டீஸ்களுக்கும் பதிலை நான் தந்து வருகிறேன். இதுவரை சுமார் 1500 வழக்கு மன்ற நோட்டீஸ்களுக்கு நான் பதிலளித்துள்ளேன். அவற்றில் பெரும்பாலானவை அதனுடன் இந்த பதிலுடனேயே நின்று விடுகிறது. சுமார் 5-6% வழக்குகள் மட்டுமே வழக்கு மன்றம் செல்கின்றன. அப்படி சென்றவற்றிலும் பல வழக்குகளில் நாம் வெற்றி பெற்றுள்ளோம் என்பதையும் இங்கு மகிழ்ச்சியுடன் தெரிவித்துக் கொள்கிறேன். ஆக இது போன்ற இந்த வழக்குகளை சந்திக்கும் போதெல்லாம் மொத்தமாக மகப்பேறு மருத்துவத்துறையை சேர்ந்தவர்களுக்குத்தான் 60 விழுக்காடுக்கு அதிகமான வழக்கறிஞர் நோட்டீஸ்களை பெற்றுள்ளோம். உண்மையும் அதுதான். காரணம், அவர்கள் 2 உயிர்களை கையாள்கிறார்கள். ஒன்று தாய், மற்றது கருவில் இருக்கும் குழந்தை. ஆக கருவில் இருக்கும் வரை அந்த குழந்தைக்கு எந்த பாதிப்பு ஏற்பட்டாலும், தாய்க்கு எந்த பாதிப்பு ஏற்பட்டாலும் அது வழக்கறிஞர் நோட்டீஸாக மாறி பல லட்சங்களை மகப்பேறு மருத்துவர்களிலிருந்து கேட்கும் ஒரு நிலை தற்போது உள்ளது. அதே நேரத்திலே அடுத்ததாக ஆர்த்தோபெடிக்ஸ், அதுக்கடுத்ததாக சர்ஜரி என பட்டியலிட்டால் உங்கள் குழந்தைகள் நல சிகிச்சை பிரிவு மிகவும் குறைவான வழக்கறிஞர் நோட்டீஸ்களைத்தான் இதுவரை பெற்றுள்ளது என்பதையும் இங்கு நான் குறிப்பிட விரும்புகிறேன். அது மட்டுமல்ல, இந்த மெடிசன் துறையை சேர்ந்த MD போன்ற மருத்துவர்களுக்கு வரக்கூடிய வழக்கறிஞர் நோட்டீஸ்களும் மிக மிக குறைவாகவே உள்ளன. ஒன்லி அறுவை சிகிச்சை நிபுணர்கள் பெறும் வழக்கறிஞர் நோட்டீஸ்களின் எண்ணிக்கை தான் மிக மிக அதிகமாக உள்ளது. அனஸ்தடிஸ்ட் ஆல்சோ அவங்களும் நிறைய வழக்கறிஞர் நோட்டீஸ்களை சந்தித்து வருகிறார்கள். இந்த குழந்தைகள் நல மருத்துவர்கள் பெறும் வழக்கறிஞர் நோட்டீஸ்களில் இதுவரை 30க்கும் மேற்பட்ட வழக்கறிஞர் நோட்டீஸ்களுக்கான பதில்களை நான் தயாரித்துள்ளேன். அதிலே குறிப்பாக கன்ஜெனிட்டல் டிஃபார்மிட்டிக்காக குழந்தைகள் நல மருத்துவர்கள் பெறும் சில வழக்கறிஞர் நோட்டீஸ்களை பற்றி நான் இங்கே குறிப்பிட விரும்புகிறேன். அதாவது, குழந்தை கருவில் இருக்கும் வரை அது அந்த தாயின் சொத்து. குழந்தை பிறந்துவிட்டால் அது அடுத்த மரபிலிருந்து அந்த குழந்தை ஒரு குழந்தைகள் நல மருத்துவன் சொத்து என்பதை நீங்கள் யாரும் மறந்துவிடக்கூடாது. குழந்தை பிறந்தபின் உடனடியாக குழந்தைகள் நல மருத்துவரிடம்தான் ஒப்படைக்கப்படுகிறது. ஈவன் நார்மல் டெலிவரியாக இருந்தாலும் அதை குழந்தைகள் நல மருத்துவர் பார்த்து சான்றிதழ் அளிக்க வேண்டும் என எத்தனையோ நீதிமன்றங்கள் சிறப்பாக ஒரு தீர்ப்பை வழங்கியுள்ளன. இருந்தாலும் பல மகப்பேறு மருத்துவர்கள் குழந்தைகள் நல மருத்துவரை தேவை ஏற்படும் பொழுதுதான் அழைக்கிறார்களே இல்லாமல் எல்லா சமயங்களிலுமே அழைப்பதில்லை. ஆனால் சிசேரியன் அறுவை சிகிச்சையின் போது 99% மருத்துவர்கள் கண்டிப்பாக குழந்தைகள் நல மருத்துவர்களை அருகில் வைத்துக் கொண்டுதான் சிசேரியன் செய்கிறார்கள் என்பதையும் இங்கே குறிப்பிட விரும்புகிறேன். குறிப்பாக சில வழக்குகளை நான் பதில் எழுதிய சில வழக்குகளை பற்றி உங்களுடன் பகிர்ந்து கொள்ள விரும்புகிறேன். சென்னையைச் சேர்ந்த ஒரு குழந்தைகள் நல மருத்துவர் அப்போது பிறந்த குழந்தையை பரிசோதித்துள்ளார். பரிசோதித்து அந்த குழந்தை எந்த விதமான பாதிப்புக்கும் உள்ளாகவில்லை, நார்மல் டெலிவரி, ஆஃப் கார் அண்ட் அதர் திங்ஸ் எல்லாமே நார்மலாக இருப்பது, கிரை, கலர், எவ்ரி திங் இஸ் ஓகே என எழுதி ஃபிட்னஸ் கொடுத்ததை அடுத்து 3 நாட்கள் கழித்து அந்த அறுவை சிகிச்சைக்கு பின் தொடர்ந்து சிசேரியன் பின் அந்த தாய்க்கு குடும்ப கட்டுப்பாடு செய்யப்பட்டுள்ளது. 3 நாட்கள் கழித்து அந்த குழந்தை இறக்க நேரிட்டது. தற்போது அந்த குழந்தையை பரிசோதித்த குழந்தைகள் நல மருத்துவருக்கு ஒரு வழக்கறிஞர் நோட்டீஸ் வந்துள்ளது. அதாவது நீங்கள் பரிசோதித்து முறையாக அந்த ரிப்போர்ட்டை கொடுக்காததால் தான் அந்த தாய்க்கு அறுவை சிகிச்சை செய்யப்பட்டது. ஆகவே உங்களுடைய அலட்சியமான பரிசோதனைக்காக நீங்கள் இழப்பீடு கொடுக்க வேண்டும் என கேட்கப்பட்டுள்ளது. இதிலிருந்து நாம் தெரிந்து கொள்ள வேண்டியது என்னென்றால், குழந்தைகள் நல மருத்துவர்கள் குழந்தை பிறந்ததும் ஒவ்வொருவரும் பாதுகாப்பாக பரிசோதித்து அதற்கான சான்றிதழ்களை வழங்குகிறோம் என்றால், இதுபோல குடும்ப கட்டுப்பாடு செய்யக்கூடிய மகளிருக்கு பிறக்கும் குழந்தைகளை மிக மிக கவனமாக நாம் பரிசோதிக்க வேண்டும். அது மட்டுமல்ல, அறுவை சிகிச்சை செய்த தாய்மார்களின் குழந்தைகளை கண்டிப்பாக நீங்கள் தினசரி சென்று பார்த்து அதன் மருத்துவ குறிப்புகளை கேஸ் ஷீட்டில் பதிவு செய்ய வேண்டும். அப்படி பதிவு செய்ய தவறினால் கண்டிப்பாக இந்த மருத்துவர் பெற்ற நோட்டீஸை போல நீங்களும் பெற வேண்டியிருக்கும். ஒன்ஸ் குடும்ப நல அறுவை சிகிச்சை செய்த குழந்தைகளின் நீங்கள் கண்டிப்பாக குறைந்தது டிஸ்சார்ஜ் ஆகும் வரையாவது தினசரி பார்த்து அதற்கான மருத்துவ குறிப்பை எழுத வேண்டும் என நான் தங்களை தாழ்மையுடன் கேட்டுக்கொள்கிறேன். அதே போல குழந்தைகள் பிறந்தவுடன் பரிசோதிக்கும் போது எல்லா கன்ஜெனிட்டல் ஹார்ட் டிசீஸ்களுமே தாய் கருவில் இருக்கும் போது ஸ்கேன் மூலம் கண்டறிய முடியாது. அதே போல பிரசவமான சில நாட்கள் வரை கூட சில கன்ஜெனிட்டல் ஹார்ட் டிசீஸ்களை யாராலும் யூகிக்க முடியாது என்று மருத்துவ நூல்களில் கூறப்பட்டுள்ளன. அதுபோல ஒரு சிசேரியன் செய்யப்பட்ட குழந்தையை முதலிலே ஒரு குழந்தைகள் நல மருத்துவர் பார்த்திருக்கிறார். அவர் எந்த வகையான குறைபாடும் இருப்பதாக கண்டறியவில்லை. ஆனால் அந்த குழந்தைக்கு சில நாட்கள் கழித்து மூச்சு திணறல் ஏற்பட்ட போது உடனடியாக கார்டியாலஜிஸ்ட் வரவழைக்கப்பட்டு அந்த குழந்தையை பரிசோதித்த போதுதான் அதற்கு ஃபேலஸ் டெட்ராலஜி உள்ளது என்பது கண்டறியப்பட்டது. அந்த ஃபேலஸ் டெட்ராலஜி உள்ளது என்பதை கண்டறியாமல் முடியாமல் போன அந்த குழந்தைகள் நல மருத்துவருக்கும் அந்த ஸ்கேன் செய்த மருத்துவருக்கும் மகப்பேறு மருத்துவருக்கும் நோட்டீஸை அனுப்பி பல லட்சம் ரூபாய்களை நஷ்டஈடாக கேட்டார்கள். முடிவில் இந்த ஃபேலஸ் டெட்ராலஜி என்பது எல்லா சமயங்களிலுமே செய்யப்படும் ஸ்கேனிலோ அல்லது குழந்தை பிறந்த சில நாட்கள் வரையிலோ கண்டறிய முடியாமல் போகலாம் என்ற வாய்ப்பை பற்றி மருத்துவ நூல்களில் சிறப்பாக கூறப்பட்டுள்ளதைத்தான் அந்த பதிலில் குறிப்பிட்டிருந்தேன். அதன் பின் அந்த வழக்கு மன்றம் செய்யவில்லை, அந்த பதிலுடனேயே நின்றுவிட்டது. அதே போல குழந்தைகள் அறுவை சிகிச்சை நிபுணர் ஒருவர் பைலேட்ரல் வெசைக்கோ யூரிட்ரிக் ரிஃப்ளெக்ஸுக்காக அறுவை சிகிச்சை செய்து வெசைக்கோ யூரிட்ரிக் அனஸ்டமோசிஸ் செய்துள்ளார். செய்து சில நாட்களாகியும் அந்த குழந்தைக்கு காய்ச்சல், யூரினரி இன்ஃபெக்ஷன் குறையவில்லை என போது அந்த குழந்தையின் பெற்றோர் வேறொரு மருத்துவரிடம் எடுத்து சென்றுள்ளார்கள். அங்கே சென்று பார்த்தபோது ஸ்கேனிலே ஒரு ஃபாரின் பாடி இன்சைட் த பிளாடர் கண்டறியப்பட்டது. அதை இன்னொரு மருத்துவர் எடுத்தார். அதை தொடர்ந்து தற்போது வழக்கு நடந்து கொண்டுள்ளது. அதை தவிர வேறு எதுவும் இங்கே நான் குறிப்பிட விரும்பவில்லை. இருந்தாலும் சில பாயிண்ட்ஸ்களை இங்கே குறிப்பிட விரும்புகிறேன். ஃபாரின் பாடி பிளாடர் மட்டுமல்ல, ஃபாரின் பாடி அப்டாமன் மட்டுமல்ல, அவர் ஃபாரின் பாடி தான் என்பதை நிரூபிக்க எந்த அறுவை சிகிச்சை நிபுணர் அறுவை செய்கிறாரோ அந்த ஃபாரின் பாடியை கண்டிப்பாக எடுத்து ப்ரெஷர் செய்ய வேண்டும். அதில் ஒரு பகுதியை பயாப்சிக்கு அனுப்ப வேண்டும். அந்த பயாப்சி ரிப்போர்ட்டில் என்ன வருகிறது என்பதையும் அவர் பாதுகாப்பாக வைத்திருக்க வேண்டும். வழக்கு மன்றம் சென்றால் இந்த ஃபாரின் பாடியின் மீதப்பட்ட ஸ்பெசிமனையும் அந்த பயாப்சி ரிப்போர்ட்டையும் காட்டினால் மட்டுமே அந்த ஃபாரின் பாடி தான் என்பதற்கான அந்த நெக்லிஜென்சியான அறுவை சிகிச்சை என்பதற்கான உத்தரவை நீதிமன்றங்கள் பிறப்பிக்க முடியும். இவை இரண்டையும் அந்த அறுவை சிகிச்சை செய்த நபர் காட்ட தவறினால் கண்டிப்பாக அந்த வழக்கிலே நோயாளி வெற்றி பெற முடியாது, மருத்துவர்கள் தான் வெற்றி பெறுவார்கள் என்பதையும் கூறிக்கொண்டு, உங்கள் பிராக்டிஸிலே இது போல் ஒரு ஃபாரின் பாடி வந்தால் தயவு செய்து அதை ப்ரிசர்வ் செய்து உரிய வழக்கு நடக்கும் நீதிமன்றங்களில் சமர்ப்பியுங்கள். ஏனென்றால் இன்ஜெக்ஷன் ஆப்ஸில் பல சமயங்களில் உடைந்த நீடில்கள் கூட உள்ளன என்ற ஒரு உண்மை சில வழக்குகளிலே வந்துள்ளன என்பதையும் தெரிவித்துக் கொள்கிறேன். அடுத்ததாக ட்ரோமேட்டிக் காசஸ், டெலிவரியின் போது ஏற்படக்கூடிய சில ட்ரோமேட்டிக் காசஸ் பற்றியும் நான் இங்கே குறிப்பிட விரும்புகிறேன். அதாவது குறிப்பாக குளூட்டியல் ஆப்சிஸ், ஒரு வழக்கிலே பிசிஜியும் போலியோவும் பிறந்த குழந்தைக்கு கொடுக்கப்பட்டுள்ளது. அதைத் தொடர்ந்து சில நாட்கள் கழித்து அந்த குழந்தைக்கு குளூட்டியல் ஆப்சிஸ் வந்துள்ளது. அந்த நோயாளியின் பெற்றோர் அதை புரிந்து கொள்ளாமல், நீங்கள் கொடுத்த பிசிஜி போலியோவால் தான் இந்த குளூட்டியல் ஆப்சிஸ் வந்தது என கூறி ஒரு வழக்கறிஞர் நோட்டீஸை அனுப்பினார்கள். ஆனால் அந்த பிசிஜியோ போலியோவோ டிராப்ஸோ குளூட்டியல் ஆப்சிஸுக்கு காரணம் அல்ல என்பதை தெளிவாக விளக்கிய பின் அவர்கள் அடங்கிவிட்டார்கள். இருந்தாலும் உண்மையில் எப்படி அந்த குழந்தைக்கு குளூட்டியல் ஆப்சிஸ் ஏற்பட்டிருக்க வேண்டும் என ஒரு அனுமானத்தில் கூற வேண்டும் என்றால், குழந்தை பிறந்ததுமே வைட்டமின் கே அந்த குளூட்டியல் பகுதியில் போடப்பட்டுள்ளது என கேஷீட்டில் பதிவு செய்யப்பட்டுள்ளது. இருந்தாலும் மருத்துவர்களுக்காக வாதாடும் நிலையில் உள்ள நாம் அதை எக்ஸ்போஸ் செய்ய முடியாது, செய்யவில்லை. அந்த வழக்கு அத்துடன் நின்றுவிட்டது என்பதையும் இங்கே தெரிவித்துக் கொள்கிறேன். அதே போல பென்டாவேலன் இன்ஜெக்ஷன் கொடுக்க போதும் இதுபோல ஆப்சிஸ் ஃபார்மேஷன் போன்ற நிலைகள் ஏற்படுகின்றன. அதே போல போட்டோ தெரப்பி கொடுக்கப்பட்ட ஒரு குழந்தைக்கு டிஸ்சார்ஜ் ஆகி 25 நாட்கள் கழித்து ஒரு ஸ்கேப்புலார் ரீஜனிலே ஒரு லம்ப் ஏற்பட்டது. அந்த லம்புக்கு காரணம் இந்த போட்டோ தெரப்பி அல்ல, அவர்கள் கூறியிருக்கிறது நோட்டீஸிலே இன்குபேட்டரில் வைத்ததால் தான் இந்த லம்ப் ஏற்பட்டுள்ளது என கூறி வழக்கறிஞர் நோட்டீஸை அனுப்பினார்கள். ஆனால் அந்த மருத்துவமனையிலே போட்டோ தெரப்பி மட்டும்தான் உள்ளதே இல்லாமல் இன்குபேட்டர் இல்லை என்பதை ஆதாரபூர்வமாக நிரூபித்து அதற்கான ஆதாரங்களையும் பில்களையும் காமித்து பதிலை கொடுத்தோம். அந்த வழக்கும் நீதிமன்றம் செல்லாமல் இந்த வழக்கறிஞர் ரிப்பளையோடு நின்றுவிட்டது என்பதையும் இங்கே பதிவு செய்ய விரும்புகிறேன். EC5 இன்ஜெக்ஷன் என்ற இன்ஜெக்ஷனை போட்டவுடன் குழந்தை அரை மணி நேரம் அங்கே காக்க வைக்கப்பட்டு வீட்டுக்கு அனுப்பப்பட்டது. வீட்டுக்கு அனுப்பப்பட்ட குழந்தைக்கு 4.5 மணி நேரங்கள் கழித்து அந்த குழந்தைக்கு மயக்க நிலை ஏற்பட்டு மருத்துவமனைக்கு எடுத்து வந்துள்ளார்கள். முறையான சிகிச்சை அளித்தும் அந்த டிஸ்னியாவையோ அந்த குழந்தையோ சரி செய்து குழந்தையை காப்பாற்ற முடியாமல் போய்விட்ட நிலையில் அவர் தற்போது ஒரு வழக்கறிஞர் நோட்டீஸை அனுப்பினார். அதிலே பல லட்சங்களை நஷ்டஈடாக கேட்டிருந்தாலும் அந்த மருத்துவர் புத்திசாலித்தனமாக போஸ்ட்மார்ட்டம் செய்ய வேண்டும் என எழுதி கேட்டுள்ளார். அவர்கள் எங்களுக்கு போஸ்ட்மார்ட்டம் தேவையில்லை என எழுதி கொடுத்து விட்டதால் அந்த வழக்கு மன்றம் செல்லும் அளவுக்கு ஒரு மெட்டீரியல் இல்லாத வழக்காக போய்விட்டது. அதே போல இன்னொரு ட்ரிபிள் ஆன்டிஜன் போடப்பட்ட ஒரு குழந்தை காலையில் போடப்பட்டது. அந்த குழந்தைக்கும் இதே போல ஆப்சிஸ் ஏற்பட்டு அதுக்கும் 5 lakhs டிமாண்ட் பண்ணி ஒரு நோட்டீஸ் வந்தது. அந்த வழக்கிலையும் நாங்கள் முறையாக சமாளித்து விட்டோம். அதே போல சில மருத்துவர்கள் முறையாக அந்த வேக்சின் எக்ஸ்பைரி ஆனதா இல்லையா என கண்டறியாமல் செவிலியர்களின் கட்டுப்பாடில் விட்டிருக்கிறார்கள். ஒரு மருத்துவர் அதுபோல ஒரு எக்ஸ்பைரி வேக்சினை போட்டு அனுப்பிவிட்டார். அந்த எக்ஸ்பைரி வேக்சினை போட்டதோடு மட்டுமல்லாமல் அந்த லேபிளையும் அந்த ஓபி சீட்டிலேயே ஒட்டி அனுப்பிவிட்டார். அதுதான் குழந்தைகள் நல மருத்துவர்கள் செய்கிறார்கள் என கேள்விப்பட்டேன். அந்த லேபிலே எக்ஸ்பைரி டேட் முடிந்து 15 நாட்கள் கழித்து அந்த ஊசி போடப்பட்டுள்ளது என்பதை கண்டறிந்த அந்த பெற்றோர் உடனடியாக மருத்துவரை அணுகியுள்ளார்கள். மருத்துவர் கூறியுள்ளார், 15 நாட்கள் வேக்சின் எக்ஸ்பைரி ஆனாலும் பொட்டன்சி போகாது, அதை நிரூபிக்க நான் வேண்டுமானால் ஆன்டிபாடி டைட்ரேஷன் செய்ய நானே எல்லா ஏற்பாடுகளையும் செய்கிறேன் என கூறியுள்ளார். அதற்கு அவர்கள் மறுத்துவிட்டார்கள். மறுத்துவிட்டதுடன் அவர் உடனடியாக வழக்கு மன்றத்துக்கும் சென்று ஒரு நோட்டீஸை அனுப்பினார். அந்த நோட்டீஸிலே எக்ஸ்பைரி வேக்சின் என்பதை நாம் எந்த வகையிலும் ஏற்றுக்கொண்டு எந்த வகையிலும் எதிர்த்து பதில் சொல்ல முடியாத அளவுக்கு ஒரு எவிடன்ஸ் இருந்தது. இருந்தாலும் இன்றைய காலகட்டத்தில் எக்ஸ்பைரி ஆகும் வேக்சின்கள் அதில் கூறப்பட்டுள்ள டேட்டை விட சில மாதங்களுக்கு போட்டாலும் எந்த பாதிப்புகளையும் ஏற்படுத்தாது, ஆன்டிபாடிகளை உற்பத்தி செய்யும் என்பதற்கான சில ஆதாரங்களை இன்டர்நெட்டிலே கண்டறிந்து அவரே அனுப்பியிருந்தார். அவற்றைத்தான் அதில் பதிலில் குறிப்பிட்டிருந்தேன். அந்த பதிலில் குறிப்பிட்டிருந்தாலும் அந்த வழக்கு தற்போது நீதிமன்றத்துக்கு சென்றுள்ளது என்பதையும் நான் தெரிவித்துக் கொள்கிறேன். அடுத்ததாக ஒரு டிசென்ட்ரியுடன் உள்நோயாளியாக செயற்பட்ட ஒரு குழந்தைக்கு 3ஆம் நாள் இன்டுசெப்ஷன் ஏற்பட்டு சிறுகுடல் கம்ப்ளீட்டாக ப்ரொலாப்ஸ் ஆகி ஒரு 1 மீட்டர் அளவுக்கு வெளியே வந்து விட்டது.
Tangamathu sir, sorry for interruption sir. So can you mix English and speak sir, because there are doctors who are also logged in outside Tamil Nadu sir, so it will be useful for them.
Yes,
Thank
sir,
you, sir.
yes, sir.
Sorry for interruption sir.
Yes, sir. After delivery, patient was admitted on baby was admitted with the dysentery. Treatment was given. After few days, patient developed into prolapse intestine due to intussusception. Following that, surgery was done. Unfortunately, they could not save the child. Now, the parents sent a notice. This only negligence due to the doctor only the baby died. What I want to tell is, whenever you get a dysentery and diarrhea cases, kindly do rectal examination and confirm whether there is any prolapse in the small bowel or other things. That is very important. Yes, this case he didn't do, even though after surgery done that we lost the case. In some other case, 4-year girl was brought for fever, blood test done, enteric fever was confirmed. So the doctor tried with so many drugs. 4 or 5 days, there is no any settlement in the fever. So the person took the child to some other hospital, some other pediatrician, where the test was repeated. Unfortunately, the test became non-enteric. It's not a case of enteric fever. He tried with some other medicine, fever settled. So now he sent a notice demanding 5 lakhs compensation. We have given reply. We stop with that. So far, we have not received any court notice. Just like that, some other case, 8 months baby brought for fever treatment, oral medicines given, 2 or 2 days oral medicine given. Few days after, baby developed polio in both limbs. So what the parent says, because of the medicine, because you didn't examine the case properly, baby developed polio. So he is demanding 25 lakhs. That is a thing. Still it is pending only with the notice and reply only, not yet gone to the court. See, one other hospital, expired drug given for a girl about 2.5 years for fever. It was given on Sundays. Sunday, the man purchased the medicine outside the hospital, not within the premises of the hospital. He didn't purchase. After few days, he came with the tablet and he told the drug given in the pharmacy is an expired drug and some other drug. You are running a pharmacy without a pharmacist and you have prescribed one thing, they have given some other thing. So you have to pay 20 lakhs for this irregularity. That's what he claimed. Unfortunately, the patient didn't purchase the medicine from the shop of the hospital. He purchased only from the outside. That was proved. So the case was settled. Yet another case, ventriculo peritoneal shunt was done 13 years back by a neurosurgeon, and the baby developed then and there some obstructions that was relieved and treated by the same neurosurgeon. After some time at the age of 13, the baby was admitted in pediatric ward in some other hospital where the neurosurgeon also working. There, he was asked to see by the physician pediatrician. He saw the case and he told it is not due to shunt obstruction, it is some other thing, so treat accordingly. That was advice given by him to the pediatrician. Unfortunately, the child died within 2 days. They claimed the neurosurgeon didn't do proper test, so death is only due to shunt obstruction. That is a negligence on the part of the neurosurgeon, so he has to pay a compensation of several lakhs. In that case, unfortunately, before death, as per his advice, CT scan brain was taken. There was a brain stem bleeding was noted in the scan, that was noted in the case sheet. So that only saved him from the paying compensation. Just I want to quote few of the poison cases we received. 2-year baby Vidya Coimbatore, the history of kerosene poison with respiratory distress, came to the hospital pediatrician with septicemia. He tried with IV fluids, and in spite of that IV fluids, patient recovered. Unfortunately, gangrene fingers was because of following IV fluids, child developed gangrene. The parents accused the gangrene is only due to the faulty treatment, faulty IV fluids. Fortunately, this was discussed in the court and they discharged the case. It is not due to injection, it is only due to septicemia. Septicemia is the cause for the gangrene of the finger. That was the judgment we received, so that case also settled. Another case, camphor poisoning for 2.5 years, baby was brought to one of the pediatrician. He examined the case and he treated the case, he saved the case, and he charged 4,600 rupees. The parents paid the 4,600. After sending home, they sent a notice stating what you have charged for the treatment is very high, and you didn't allow us to stay with the child while treating the case. So for this negligence, you have to pay 5 lakhs to us. That was the notice. Fortunately, this case also didn't go to the court because the doctor, what he did, already paid 4,600, means that is a proper money. In many of the courts, regarding the payment, no judge will open their mouth. They won't give any verdict regarding the payment of money or a huge payment of money. They won't interfere. So in this case also, nobody asked why you collect 4,600 other things. But in this case also solved with the reply only. Another case on organ. Yes, sir.
Sir, 5 more minutes, sir.
Yes, sir. Yes, sir. Yes, madam.
5 more minutes, sir. Thank you, sir.
Okay, madam. Okay, madam. Yet another organophosphorus compound, organophosphorus case poisoning. One school, 12-year boy, after examine, he went home in the evening and came to the school in the afternoon. Before writing an examination, he fainted. At once, the boy was taken to the nearby hospital. Nearby hospital, doctor diagnosed as organic phosphorus poisoning, and he gave up first aid. And at once, he referred the case to GH. After treatment at GH, the baby died. The boy died. After some time, the parents issued a notice demanding several lakhs from the teacher and doctor who treated the case, and we replied properly. That also stopped with the reply. So whenever we receive a poison case, whether it is a pediatric or it is adult or anything, we have to make a AR entry. In all the 3 cases, they didn't do any AR entry. If you make an AR entry And if you suspect the case, you send a police report intimation, then thereby we can save our skin from these unnecessary legal notices. That is my advice. So these are all the cases, important cases. So far I have written, I have given a reply on the pediatric side. Few more cases are there. Since there is no time, I don't want to go through all those cases. Thank you very much for giving me this opportunity to present my cases before Pediatric Association members. Thank you very much. Thank you.
Thank you, sir. That was an excellent presentation of all the pediatric cases from your collection of the legal as a member of the legal committee. And you've also given us some learning points how in each case the pediatrician should document things, and you have given us suggestions. Thank you very much, sir. That was a very excellent session, sir. Thank you, sir.
Thank you, madam.
The next talk would be by Dr. A. Subramaniam. Dr. Subramaniam is a senior pediatrician, and he has served in the IAP TNSC in various positions as an EB member, as a vice president, and then finally the prestigious post of president of the TNSC IAP in 2010. He has also been given the Active Pediatrician Award during the year of inception. He has been previously worked as a medical superintendent and legal coordinator at Kaveri Hospital, Trichy. And currently, he is the CEO of Thangam Hospital and Cancer Center, Namakkal. Apart from being a pediatrician and his professional work, his other areas of interest are music, counseling, law, and administration. And therefore, he is the right person to talk to us on legal challenges in hospital admin's career. Over to Dr. A. Subramaniam.
Thank you very much, Dr. Nandini, and all my fellow IAPNs and the senior surgeon, Dr. Thangabathu, ladies and gentlemen. I'm going to the subject, and she has told my connection at Trichy, before that Tirunelveli Pediatrician Corporation Service. Now the admin job is nothing but a crown of thorns. That is, when you oblige, you get a doubtful friend, and when you don't oblige, you get a definite hostile person. If the patient is cute, they say the billing is high, and if not, the treatment is wrong. Lawyer-oriented question by the patient. He is a doctor by the Google Medical College from WhatsApp University, and the doctor with the disclaimer answer is going about. And admin job, just at a scarf that felt never around in Hamlet of Shakespeare. Beyond his control, everything happens, but he is only held responsible. What are the tricky cases? Cases coming to us without money, without attender, something suspicious. Sometimes second wife brings the case, later on the first wife comes, something like that. So what are the essential qualities we need to have healthcare? ABC, just like airway, breathing, etc. Attitude, behavior, communication, documentation, empathy. In CD, communication about documentation and documentation about communication. If all these things are good, your feedback will be good. Now my experience, what I experienced, what I learned from others, everything I have given. That is, first was a kidney transplant case. The mother gave the kidney to the daughter. And unfortunately for the daughter, on the 4th day, she went in for cortical necrosis. So no other go, we had to do nephrectomy. But the husband would not allow us to do nephrectomy. He asked one question. That is, the mother had the child in her womb for the 10 months in the antenatal. The kidney worked. The same mother's kidney in daughter's abdomen. Why it is not working? I say you have given the mother's kidney to some other person and transplanted some old sick kidney to my wife, he said. So then it was challenged. Luckily, mother's test, DNA test was there, and the nephrectomized kidney, the DNA test, and the daughter's blood. With all these things, scientifically, the case could be won. It did not go to the court at all. And then a very healthy adolescent boy, he came. He actually came with Acinetobacter septicemia. That is, he was admitted, lived for 3 days or 7 days or something like that, and then he died. But he was such a healthy boy before. The father said, "This Acinetobacter is a nosocomial. It came from your hospital, etc." Luckily, our nurses had done zero culture at the casualty when he was suffering from Acinetobacter. So we could rather answer the case like that. And then a 32-year-old boy came with heart attack and brought by a mob, that is over 30 or 40 people. And unfortunately, the patient died within several hours. So they said, "Okay, heart attack. We are taking the boy, that is body, etc." But when we were about to dress the person, we saw the back of the boy with all blisters, trauma, everything. So got suspicious. We said we would like to do postmortem. We said refer the case to GH, mortuary, police, etc. But they couldn't. The mob was very in frenzy. And what happened? Because the doctor, nurse, or 3 or 4, they are 30 in number. I just allowed the case to go with them. Instead, called the police over the phone and said, "Such a suspicious thing is going." They simply went there. The parents were crying, saying the boy was murdered like this. And the entire mob was arrested. Next. This is a very, very interesting, I would say, unique thing in the whole of my life, I would say. That is in CCU, the case of husband and wife, that is the 28 year and 27 years, it's a love marriage. The wife was brought and found to be in the angio, double vessel block. So at that time, the husband said, have I loved a sick person? Then I don't want it. He was not for spending anything. And the parents came. This lady went with him, did not answer did not pay heed to my advice. So he also didn't pay. We said we would do it through the CM scheme. Both of them were in frenzy saying, "We will not allow the operation." At that time, the inspector was called and he came inside the cath lab in the cath lab suit and asked the lady. She said, "These people are prepared to do it free of cost. Please save me." So with that video consent, it was completely videoed. With that video consent, inspector came out and said, "Whoever is objecting will be taken under Gunda's Act." So they kept quiet. The operation successful and the lady discharged. It's a very unique experience. Next, another thing I tell you, this is something for a case which I observed elsewhere. That is a doctor. He signed for his driver's brother's daughter-in-law who died. 3 days later, he signed in absentia. He didn't see the patient. He gave the death certificate saying myocardial infarction. Okay, 1 week passed. At the 5th day or 6th day, a cow was found dead in that street. And it was sent for postmortem, found to be cyanide poisoning. Then the entire police, they took into action and found who died in this street. And the lady was there. She was a college lecturer and dug out from the burial, found that she was also cyanide poisoning, etc., etc. The case was going on, found everybody guilty. That's a different thing. But the doctor was the one who was punished. Why? Given a fake certificate. He lost the degree, he lost the government service, put behind bars for 7 years rigorous imprisonment. So the moral is, a doctor is buried under his signature, no in absentia signature. And then a newly married lady came with 80% burns, sick but conscious, innocent, loving husband crying nearby. At that time, anyhow, she was definitely going to die within a few hours. So I was just talking to the lady, asking her, "Do you find that anybody is at fault?" She said, "No, Karthike Deepam, I am the one at fault. He is so loving to me." Then I said, "If you don't mind, could you please tell this to the magistrate?" Brought the magistrate. She said, "Husband is innocent." And of course, she died that night. But luckily, police could not touch that person because it was marriage within 1 year. What would have happened to the husband, you see, if this dying declaration was not given. And another thing is a newborn brought by friend without the parents. We have, the thing is, it was brought within 3 hours, surfactant given, all the expenditure done, everything he paid. So at the end of 24 hours, we asked the person, What about the mother? Oh, she is under cesarean. What about the father? Out of station. What about the reference? Oh, you have got it here. That was the lady doctor from PHC. I said, she is not the obstetrician. No, that obstetrician is so busy. Then something clicked. At the end of 36 hours, we said, now that you have not brought, we have done all the emergency treatment. I'm going to tell the police, whenever an action of the hospital over a newborn about whom we don't know any bona fides of the parents, etc. No, please don't tell like that. No, there is no other way. I've got to tell. He simply knelt down, begging on bended knees, asking, this was a child. I got it from the father by paying 1 lakh. The twin child, only the second child is there. Then I said, either I report to the police or you can take the child. He took the child and left. This is one thing. And another person came with his wife for heart attack, died within 48 hours. 1 month later, the lawyer comes to the first wife saying, sir, you have given the body to somebody. The wife is here. Marriage certificate is here. Marriage photo is here, etc. I said, marriage certificate does not confirm a person is married for years. Even the next day, you can have a divorce certificate. So whether you have got a legal or certificate, anyway, it is not my botheration. The patient signed and told she is my wife. There ends the matter. Anything you want to challenge, please go to the court. You would rather file a petition and then say she is the official wife and then have it changed with the commissioner. Because I had been in the birth and death section in corporation for 20 years, I know all these rules, so I could advise them. Another, a father brought her daughter, 35, married, for a psychiatric counseling because she had some schizophrenic disturbance, etc. And everything was treated. After she left, 1 hour later, the husband came. Oh, my wife was suffering. I would like to have a copy of the OP ticket, etc. Then you can get it from your wife. No, we are not in talking terms. Then I said, psychiatrist treatment cannot be shared to anybody unless the patient says you can. That was something very careful. And another thing, this happened in Tirunelveli. That is an unmarried pregnancy. That is, a lady was hiding her pregnancy from the parents for so long. Suddenly came to the hospital for delivery. And after the delivery, the parents became so furious. They wanted to kill the child because it's unmarried. But the lady said, I am a mother now. I would like to protect the child. So after counseling both of them and got the child, gave it to the government social welfare board for adoption, and then handed over the daughter to the parents. This was a very unique, very emotional, sensational thing. And then in work spot injuries, please give first aid emergency treatment. But before doing elective procedure, see that the mother or father or husband or wife, whoever comes, because anything you do with the factory, patient and the hospital, every chance of the relatives filing with the union saying, oh, this was something those people hand in gloves to the factory, they did. So work spot injuries, be careful and do not entertain discharges with the tubes, IV needle, etc. Definitely it may prove detrimental against you. And I have suffered in this. I don't want to detail much. There are other points that time is getting on. In a hospital, a girl treated with injuries, that is MLC case, went AMA, treated in another hospital where they found pregnancy and then ruptured genitalia, etc. Urine for pregnancy, it was a rape. And finally, the moral of the story is examination of an adolescent patient, a girl child under suspicion. Please do it by an obstetrician and urine for pregnancy. And then there is no medical parole in a hospital. There are so many people asking, sir, for 4 hours, Vinayak Chavithi is there. For 4 hours, I would like to go for Dasara. Then I will bring the child. It was a pediatric case. I said nothing doing because the insurance will not allow. Anything that happens to the child or they get admitted in another hospital without your knowledge, 2 entries going on, 2 hospitals entering the same person, then this hospital or parent hospital will get into problem. No medical parole. And brought death cases, always you can certify death cases, but you cannot certify cause of death at all. Discharge in case, even if you discharge the case, they come to you and say, sir, after discharge at night, the case died. You cannot give death certificate. You can only give a death certificate. And do not give cause of death if you did not treat. And mind you, in any consumer court, whenever you have got a doctor's notes, the nursing notes, both must synchronize. That's very important. And transport protocol, ambulance medicine, etc. the doctor, nurse must accompany, because ambulance is taken as an extension counter of a hospital. If anything that happens on the way, the hospital has to certify. So, and handing over to the GH or higher center, please document it with all consent, etc. And another important thing, in ICU, when the patient is unconscious, the son would say, sir, he has got all the money, please allow me to, the bank manager has come, allow me to have the thumb impression. Absolutely don't allow, because when once you have the thumb impression, he can fill in any amount, he can fill 10 lakhs and give you 2 lakhs, take 8 lakhs, and the brother will come. And my elder brother took out of this thumb impression. When it comes to the court, your ICU notes will say, this person is unconscious. And thumb impression will say, the banker will take all the money. So what will happen? Hospital has been in connivance with the eldest son. So the youngest son will file a case against the hospital. So and similarly, check, will, everything. And even thumb impression from a blind patient, I tell you, have the notary public or something, all have judicial. You ask your lawyer and then do it. Do not do it by yourself. And the patient, if the patient comes alone, if a team of doctors are going to treat, doesn't matter, you can go there. If one doctor is treating, when a patient is coming, anything happens to the patient, the doctor will get into trouble. And the doctor has to take the responsibility of regarding audio consent, video consent, everything. I tell you, wherever hospital you are working, please have a pen drive, video consult, have a copy, because at the time of any court case after 5 years, this hospital will say, sir, our server has cracked down, we don't have evidence. So the consultant, you have to save your skin. Have a pen drive of all the cases, video consent you are doing. Similarly, the hospital has to have backup of all investigation, not depend on only one server. ECG, immediately take Xerox copy, or else it will fade away, because you have to prove what is the investigation and other thing. And similarly, writing alcoholic in the first inspection report by RMO or anything, please don't do it, because in one case, the patient argued in the court saying that, sir, I had the alcohol bottle, it got broken. The entire alcohol fell in my shirt and other thing. So it smelled alcohol. He wrote it. Has he examined blood alcohol? Nothing. Because of that, my insurance is denied. So I will not pay the hospital. Patient challenged it. Hospital lost it. So either write alcoholic means prove it, or else don't write. And blood transfusion. In a hospital in Delhi, the dengue patient given 6 bottles of blood. Finally, she said at the time of discharge, having paid 5 lakhs to the hospital, she wrote, I am in an emotional trauma because these people had 6 bottles. I was panic. I was in panic. Consent not got. Finally, it was fined 5 lakhs and she got back the 5 lakhs. And while treating AIDS, of course, privacy, confidentiality, everything I accept, consent form, everything. But in ICU, when you see the male member as AIDS, whether it is necessary to tell the wife, social responsibility says it must be told. You can refer NACO or this. And do not entertain the word DNR. Do not resuscitate. Nothing like that. It's a very big subject. I cannot talk now much on that. But DNR is not allowed. And insurance department will ask for the case sheet. You have got to give, provided insurance and you have a MOU saying patient's case sheet must be given. And similarly, whenever you have a patient, get a blanket sign. In the event of any claims with any insurance, now or later, as the case may be, I have no objection in sharing my case sheet. If you have that, you are safe. In fact, there is a case about this. For want of time, I'm not explaining that. And medical certificate 1990 Madras High Court under Justice Natarajan has pronounced, because it was a time when I was there, got that. That is, it is the doctor's responsibility to prove the certificate identity of the person, because they ask the person, doctor, you have given the certificate. You know this person? Sir, I can, Milord, I can say this certificate is mine. Signature is mine. This patient, this person suffered from this disease. I have written. Whether this person and this person standing in the cabin are the same, I do not know. At that time, that justice said, it is the doctor's. Either you take thumb impression, you take a photo, you take marks of identification, but doctor has to prove. You cannot be giving just like that all and sundry medical certificate. And all investigations to be back. ECG, Xerox, I have told you. Failure of treatment is accepted, but not negligence. And then the patient has got the right to get a copy of his sheet. And according to Madurai High Court, it has been told you have to give within 3 working days as per High Court. And similarly, if the police is asking for interim summary for an MLC, that also you have got to give. And during treatment, investigation, Xerox, if you ask for second opinion, that also you must give. And as our professor, Dr. Surgeon, our senior person told, if the patient dies and the relatives raise a complaint about the death, please ask for non-legal postmortem by choice. And if they refuse, get it in writing, it will help you in the court. And medical tourism, people with tourist visa are not eligible for elective operation. If it is emergency, okay, get the passport, visa details, send it to the police department, and also a copy to the ambassador or high commission. If attender is not available, their jewels and other things, you please make a mention in the letter and also to the police. And regularly employment or any training for foreigners going through such procedures, everything, as I told you, it is only through the government and other things. Just like that, you cannot have training. And if, for example, one thing happened in Tirunelveli, one thing, we appointed a person for 1 year. Second time, the notice came from the collector. They belong to the Mandapam Agadigal camp. This Ceylon repatriate. How come you appointed? Then, since people were known to us without any problem, we got it relieved. Because you are not supposed to appoint people belonging to Bangladesh, Ceylon, because their pay is little, etc. Don't do it. And visiting surgeons, oh, they don't belong to our hospital, nothing doing. You have to get their degree, validity, everything. You have got to have a copy. And out of court settlement, it's a big chapter. Time doesn't permit to talk about it. And then nurse talking like a doctor, very, very important. And what happened in Tirunelveli, my senior pediatrician was seeing, and he has gone to the nursing home. And at that time, the lady diarrhea pata, ayati, cholera marla pode, abdina. The people, relatives, because child going like cholera means they rush to the doctor. He had a big crowd. You come to the nursing home and see. Then he came because the nurse said cholera, hanging drop method, everything was done, everything negative. And he told me, yes, hereafter don't appoint nurses like this. We are all emotional because that is very important. And then in a surgery, the removed specimen must be shown to the patient. In one particular case, it was done, not shown, and the whole disease record, as per the disease process, it record. But what the patient said, I tell you, first time they didn't do, got the fees, now only they have done. So please show it to them. If the patient is critical, unaffordable, first aid, you do it free even and refer it to GH. You cannot refuse. And cases brought dead and left orphaned in the casualty, go to the police station. And do not employ alternate system of medicine, very important, because so many other reasons people are appointing other systems of medicine. In Hyderabad, in a dialysis center, a BIM was 10 years doing dialysis. He was an excellent guy, but and the nephrologist over the phone said, this thing is too much. There is creatinine is high. You do the dialysis, I will come. Then it was done at 8 o'clock dialysis. Then he phoned about 10 o'clock. Should I come? Sir, it's quite stable. Don't bother. Okay, I'll come tomorrow. And tomorrow when he came at 8:30 and 8 o'clock, it went in for cardiac arrest and died. It came to the court. And finally, what was told was, doctor fined 10 lakhs, hospital fined 1 crore. And of course, it has gone for appeal. That's a different thing. So if you are having anybody such, put the term as observer, transcriptionist. And whenever they write something, you ask the MS or MD or DM or MCH, somebody let them countersign over that. So they can be taken as transcriptionists. And this is the most important training we must have. Do not keep the patients in darkness. No tall claim or false hopes. Do not belittle any other hospital or colleague. Convey promptly and document it. Written consent, audio consent, video consent. Communications, there are 23 types. I'm only telling you 6 types I'm going to tell. One is over communication, talking too much, going on talking, repeatedly talking. You yourself will fall a prey to your communication. Brevity is the soul of it. Be brief and with relevant details. And wrong communication, conveying information of the wrong patient to the wrong person with all things wrong, it will prove against you. And false communication, giving tall claims and false hopes. Delayed communication, so at 6 o'clock morning, you would have found out something, but you tell the patient at 6 o'clock in the night means he will say, had you told me at 7 o'clock, I would have taken you to some other hospital. And no communication, you have not communicated at all. That is the doldrum. And passing the message through somebody, you are so busy, you ask somebody to do it, you would have either overdone or underdone. Dubbing voice is always dangerous. And Aadhaar card, in Aadhaar card, another important thing, a person came after 5 years saying, oh, my husband died. At that time, they wrongly written the name. This is the name. I said, where is the Aadhaar card? Oh, here you got the Aadhaar card. And everybody, I had a great pleasure in doing that. Having moved in birth and death, I could see the Aadhaar card. Aadhaar card has got an issue date at the last line as a small micro word. I said, after death, you have got this Aadhaar card. How come? It is something fictitious. And after that, nobody came. Aadhaar card must correct spelling, correcting, name, age, everything when it was issued, etc. And then have the TNMC number done. Additional qualification must be registered, because without additional qualification, MBBS, MS, MBBS doing the operation, MS not put under additional qualification. When the case comes, a person, doctor was punished because saying your MS is not written there. He had to pay a penalty. Similarly, a Tamil Nadu doctor at Bangalore practiced for 25 years, did not get Karnataka Council. He lost the case because he was not a Karnataka doctor. Even for a Pondicherry car, we are registering Tamil Nadu number if they come here. Stick on to TNMC, CEA, everything, all the rules are there. Earn 30 credit hours per 5 years. Please follow these things regularly, because at every stage, it may go against you. And end of life care, this is a very big chapter. I cannot talk about that. And now,
excuse me, doctor, we have 3 more minutes. 3 more minutes.
Done. I will give you 1 minute. This end of life care, the specialist, and then MD, RMO, or 4 people under a court has to get this. And PPLSS very, very, very mandatory. The hospital, the doctor, all of them, if they are a PPLSS, one lawyer can argue for everybody. And I'm pronounced to my mentors about all that, what all I have learned in communication, management, organizing, admin, everything I owe it to my parents, legendary parents, love, wit and knowledge, wisdom they wrote. Dr. A.S. Krishnan Tirunelveli, my guru, my astute leader, Reverend Father Ludraj, my godfather, hand-holding teacher, mentor in everything. And also Sudeep Jain, IAS, who is inspired of perfection, execution, Harmanda, who taught me safety, Dr. Manivannan, the genius in hospital administration, e-management, Dr. Jyoti Clara, walking inside nursing, and regarding legal, Dr. Cheran. Thanks to my secretary, Ms. Indupriya, for compilation and computer resumes, and case sheet retention, 3 years, MLC, no time limit, pediatrics, till the child becomes major, plus 3 years, 21. And example is the best servant, experience is the best teacher. The secret of my success is my better half. And also thanks to Tangam Cancer Center. And thank you all very much. Thank you, my Lord. Thank you. Over to you, Dr. Andhani. Thank you very much.
Thank you. Thank you, Dr. Subramaniam. I think so many cases which you had shared as a challenge in your admin's career. And that had also a lot of messages that we could think. And I think that very interesting thing was the Aadhaar card, where you said that issue date is there. I think all of us, it's an information. Thank you very much for that very nice lecture. And next we would go to the third presentation by Dr. Satish. Can you stop sharing, Doctor?
Yeah.
Yeah, Dr. Satish is a senior consultant pediatrician in Apollo Children's Hospital, Chennai. He has been the past president of the Chennai City branch of Indian Academy of Pediatrics and a member of the specialty board of the National Board of Examination. And he's going to talk to us on legal issues in office practice. Over to you, Dr. Satish.
Thank you, madam, for the kind introduction. Thank you, IAP TNSC, for giving me this opportunity. Special thanks to the convener, Dr. Thangavelu, who has handpicked me for making this presentation. Actually, the topic for today is legal issues in office practice. I'm in no envious position. My predecessors have exhaustively illustrated, and they're given excellent talks and many carry-home messages. But now, for a change, I'll be talking on office practice, the primary prevention of how to avoid the litigations and legal hassles by recapitulating the usual vulnerabilities. See, in office practice is something very tricky. Suddenly you see the clientele increasing. If you are good, dutiful, diligent, certainly the clientele will increase. If 4 patients bring 4 more patients, it's a summation. If after a while you will see that 4 patients bring 4 to the power of 4 patients, it is 256 patients, and therefore it is very important to have a strategy of clinic administration. All days are not good days. One has to adhere to standard procedures and practice profession with duty, devotion, and diligence. You have to look at every patient as a potential litigant, not because you do not trust the patient, but because that gives you some a power, a will that you should be diligent, you should be dutiful. If you worship your work, definitely you will be doing it with caution. Now, I'll be taking you through the usual streaming, what generally happens in a clinic setting. Scheduling of appointments, adequacy of examination, medico-legal scenarios, acute illness in the waiting hall suddenly arising, emergency case, prescription clarity, medical records, medical certificate, a broad dead patient coming to the clinic, telemedicine, and finally wrapping up. Now, the scheduling appointments. You can schedule maximum of 5 patients in 1 hour slot. And if you become busier, you probably about 10 to 20% increase in the clientele, you can stretch your time. If it is 20 to 30% increase in your clientele, you must have a skilled paramedic like a physician assistant to help you so that there's no dilution in the quality of work delivered. If it is about 50 to 60% increase, have a young assistant who is junior to you, who can be doing a stereotypic jobs. If it is about 80% increase in the clientele, and you certainly cannot do away with the junior assistant, you have to have a contemporary with something like a comparable competence, an associate for you. So you should spend time with the patient, then only the inhibitions will go for the parents also to really share with you what they want to share. Spend at least 12 minutes with each patient. See each patient as a long case at the first visit. Document the history of allergy or any red alerts. What do I mean by red alerts? Suppose if there is it's a case of a newborn follow-up you're seeing in the 2nd month, if that be the case where there was phototherapy given for a serum bilirubin of 19 milligrams, and so definitely you should be conscious of checking the auditory now. If you have to see whether any hearing test has been done, or you had order for the hearing test at least for the 4th month. If there has been a prematurity, you should look for ROP and you have to be alert about it. If there's something has been like your undescended testis was recorded in the discharge summary, you have to follow up the undescended testis. And so the subsequent, this is what I mean by note the red alerts. In the subsequent visits, do point of care treatment and address the red alerts if any. Secondly, a scenario where the patient is brought back to you again because the symptom in the first setting has not got resolved. For example, patient has come with fever, you have treated for fever still persists, and the parents have chosen to come back to you. Thank the parents for giving you the second chance. See carefully this time. Do not charge fees. Adopt All India Radio approach, AIR, admit or investigate or refer. So now the allergy, this is very important that you should elicit history of allergy. There are many medical legal cases which have come up because this allergy history was not recorded. Do not expect the patient to volunteer the information. You have to elicit it actively. Polypharmacy, and if there are many crossopathies, homeopathy, allopathy, several times you see our own colleagues prescribing some Ayurvedic preparations like Leaf 52, Septulin, Bonisan, and these preparations are banned. Delhi Medical Council is already banned, and if there be any adverse effect, nobody can attribute it. It can be patients can attribute it to that, and you have no license to write the drugs of another specialty. So one has to have a minimum knowledge of law. The ignorance of law is no excuse. So now I'll just take you through a few medical legal scenarios. This is about a case of a child who was seen thrice for various minor issues such as conjunctivitis, immunization work, etc. In the 4th visit, a right-sided undescended testis, impalpable testis were diagnosed. USG scrotum picked up the testis intra-abdominally, but with discrepancy in size compared to the normal testis. Pediatric surgeon commented that this is a late referral. I don't think anything wrong with pediatricians to have passed on that committee. In fact, a later referral, the angry patients picked up this issue with the doctor. And thankfully for the doctor, the same thing was mentioned in the discharge summary of the maternity facility advising postnatal follow-up. So the clause of contributory negligence was invoked and the doctor heaved a sigh of relief. The doctor might have heaved a sigh of relief, but definitely there's a deficiency of service on the part of the doctor, and therefore one should have a good protocol. I'll take this opportunity to talk about what is contributory negligence. It means not coming up for follow-up, failure to follow instructions, investigations not being done, failure to disclose prior records, failure to consult patient specialists. The other type of negligence is act of omission, act of commission. The act of omission is not attending patients, not examining carefully, not investigating carefully, not obtaining proper consent, failure to give a standard treatment, not taking proper precautions, failure to leave proper instructions, failure to advise hospitalization, abandoning without making alternatives. Now, this is about scenario 2. An infant was seen by a pediatrician twice for minor issues. On the 4th visit, the parents brought the child with a white reflex in the eye. The ophthalmologist diagnosed retinoblastoma. Enucleation was suggested. There was an angry outburst from the parents thinking that this was diagnosed only in the 4th visit and early diagnosis might have averted enucleation. But the doctor tried to explain, but he could not do anything. So during the follow-up, when the other eye was also affected, despite the ophthalmologist following up the other eye after enucleation in one eye, the disease record on the other eye, the parents mellowed down saying that this was an act of God, and therefore probably nothing more happened to the doctor. But then, even then, there has to be a proper protocol for the treating doctor to have, that you should examine the red reflex in the first visit when you're seeing the newborn baby and follow it up in the subsequent visits. Now, another patient, a premature infant born in a hospital, was stabilized and discharged. The infant was then followed up in the child clinic in the same hospital. Later, the child was found to have ROP, retinopathy of prematurity, with visual disturbance. The parents sued in the court of law for omission of diagnosis of ROP in the discharge summary and the follow-up in this premature infant. So the case of medical negligence was invoked, and both the hospital and pediatrician were convicted. There was a sensational case about this, where 1.08 crores was the amount of the compensation that was levied by the court. As the child was prescribed cotrimoxazole for urinary tract infection, drug reaction occurred. Parents argued, saying that the doctor did not elicit history of allergy. Parents then produced a predated paper stating that the child had sulfur allergy signed by a dermatologist, predated to the date of consultation. The doctor accepted the allegation that he did not elicit the history. In the same breath, he attributed contributory negligence on the parents for not disclosing this paper at the time of consultation. The case was closed after arbitration agreement out of court. So now, these are to tell you a few examples of what could be, what are all things that have happened to other colleagues and what have been the judgments delivered. Now, I'm coming to say that every doctor should have his own protocol of how to deal with it. That's why I said, see the patient as a long case in the first visit, make note of the red alerts, and subsequently it could be point of care. Now, I'll coming to the second scenario, a symptomatic patient. So in the waiting hall, there can be an emergency situation. Patients who are waiting in the waiting hall, suddenly one in the waiting hall can throw a seizure. It's a febrile child who has been waiting to see you. He throws a fit, or it could be a child with fever, with subtle dehydration. The adolescent girl faints. It's a syncopal episode. But what the doctor has to do, immediately treat and stabilize the patient. Do not worry about the time that is gone, but it's important to treat and stabilize the patient. If you want to hospitalize, do so. If you want to refer to tertiary care hospital, do so, but you have to stabilize before transport. Even the transport center, the doctor has already, Dr. Subramanian has so beautifully said that ambulance is an extended arm of the tertiary care center, and therefore you have to wait till the ambulance arrives. Or if the ambulance, there is no doctor, it's only the ambulance staff, the paramedical staff are there for picking up. You have to go along with the patient and hand over to the doctor. Suppose an emergency situation occurs, a patient who's not in the list of appointments today, somebody suddenly comes, say an unconscious patient, burns, a fall victim, a trauma, head injury, or something hazardous has happened so suddenly, like a child with seizure. So what you should do, if the child, then you cannot refuse whatever be. You cannot say, it's a burns case, it could be medical legal, I will not see. No, it is wrong. Definitely the doctor cannot refuse. The law is well settled in this case. The prescription clarity. In the OP practice, this is really nowadays problem, and therefore the digitalization has been prescribed legible. It should be legible without any ambiguity, because so many times that there could be mistakes. There are instances where diawall for dionyl, and therefore the wrong prescriptions have been given, the wrong medications have been dispensed, and therefore the clarity of prescription is really important. The medical legal record must mention identity marks. Already Dr. Subramanian has mentioned the characteristics of a proper prescription according to the guidelines is the diagnosis to be mentioned, drug name should be eligible, precise, understandable instructions in capitals, telephone number should be there, mention red flags with need to report and review date, verify if the prescription was understood by the caregiver. Should you hold medical records in the OP setting? I did not know that we should do, but I was not doing. I came to know now. The medical records, even in OP setting, have to be preserved. How long you should preserve the medical records? All records except MLC for 3 years, MLC records for 10 years, or until the case is disposed. Better to digitalize all the OP documents and preserve forever. And Dr. Subramanian has added the fourth point, if it is pediatric patient, it should be at least for 10 years or until the child becomes major. The second activity that goes on in our clinic is about immunization. Should we get consent for immunization? Immunization is one of the interventional thing. Should we get consent? There is an opinion, is a divided opinion about that. The Advisory Committee of Indian Academy of Pediatrics says the implied consent will suffice, meaning the parent has brought the child for the activity of immunization. That means he has given consent. It is an implied consent that will suffice. But the medical legal group of IAP has said that that would not suffice. You need an informed consent. I think the IAP had to come out with a consensus. Now, there are certain things about the immunization, whether there are two things. You have an NIP schedule, IAP schedule, and there are certain vaccines which are not included in the NIP schedule. The dilemma is whether to prescribe, whether to insist that these vaccines have to be given. They say one-to-one consultation, one-to-one discussion, you could give these vaccines. But there's a court ruling that this is a case where a child had been treated for typhoid fever, discharged without vaccine advice and mentioned on the discharge card. The typhoid fever relapsed. The court observed that not advising vaccine is negligence, and the court went against the doctor in hospital. If that be the case, can this situation be not extrapolated? But should you advise the typhoid vaccine for all, though it is not included in the NIP schedule? So I think you have to take a written consent that we have suggested the patient has not taken. So there was a previous judgment in pneumococcal vaccine case where the doctor has advised pneumococcal vaccine, parent have refused. The child had necrotizing pneumonia, the child died. They picked up the case with the doctor saying that pneumococcal vaccine was not suggested. Fortunately, the immunization record had a mention that doctor has in fact prescribed, advised, the grandmother refused. He made that noting and he escaped because of good documentation. And therefore, it means that even immunization activity, the consent, you have to explain to the patient what the vaccine will do, what will be the adverse reactions, whether you have the minimum machinery to at least save the vitals when any adverse reaction occurs. And if therefore there could be a small risk of anything untoward, even death, that also has to be mentioned. And if mentioning all that, you had to take the written signature. And I think one has to really see these things do take place. Next is about medical certificates. Dr. Subramanian has already beautifully told about medical certificates. You must have a prototype of medical certificates in printed format, and it should be given in duplicate. Issue after examining a genuine patient, certificate should have a serial number. One copy must be with you. Besides the signature of patient, write also 2 identification marks of the patient. Don't issue a certificate more than 15 days in one go. Then regarding the protocol for referral, if you are not available for consultation, you cannot abandon the clinic and run away. You can say that your clinic is closed. You have to have someone, at least if not someone sitting in your clinic, you have to have someone designated for that. Please go to so-and-so doctor of comparable knowledge and competence. This comparable competence is really important because the cases arise because the doctor has referred one patient in his absence to another junior colleague of his, where something went wrong with the patient, the case died, and therefore the case picked up with the first doctor. The first doctor was convicted because the doctor to whom he referred was not of comparable competence. Next is scenario of a dead patient brought into the clinic. Never refuse to see. If they say that no, I can't see the dead patient, but it is impossible to say the dead patient. You have to first examine, ascertain by usual clinical methods. After that, you should have at least a pulse oximeter tracing where there is a straight line recorded for at least 30 minutes. If you want to attempt any resuscitation, if some motor activity does take place now and then, if you attempt, do not charge fees for that. You may issue a death information report, but not death certificate unless you know the case details. If it is, for example, if it is CKD, you know about this patient, the patient is in a debilitated condition, he comes with the broad death. Probably you could issue, if you know, without knowing the case details, you can only give death information report. If a group of people gather around, please call the police station in anticipation of trouble because it could be some mob violence. Then a word about telemedicine. So this telemedicine has become, there have been recent guidelines. The Supreme Court has banned telephonic consultation 10 years ago, but now recently in 2020, the central government and in the Indian Medical Council have come in supersession of the Supreme Court judgment to take special guidelines. They're given the recent guidelines. And so e-prescriptions, investigations also could be advised. Prescription should be with digital signature. One could charge fees.
Excuse me, doctor, 3 more minutes.
Yeah, madam. No, a change has come over the years. Many medical legal cases have changed the practice approach. Faith has been replaced by contract. One has to change with time. Mishaps are part and parcel of practice. Accept and face it. This change has come because of several judgments, IMA versus VP Shanta, some case related to comments, the case regarding lack of documentation, a case regarding the doctor refused to treat an emergency state, and related to cross-specialty practice. What is golden rule is anticipation, documentation, communication, limitations, ethics, and introspection. Jousting is another things which are happening. Jousting means a professional colleague talks adversely about the previous treatment. That should be avoided. Wrapping up, the medical practice is no longer a faith, it's a contract. Minimum knowledge of medical law is a must. Remember 3 Ds, duty, devotion, diligence. Tadakshara mantra is Ashwini, ASWINI, art, science, wisdom, intelligence. Never refuse and introspect. Avoid professional jousting. Thank you.
Thank you, Dr. Satish. That was a real excellent presentation with a lot of medical legal cases and a lot of carry home messages. Thank you for that very wonderful session. And now, can you stop sharing, doctor?
Yeah, madam. Yes, madam. Thank you, madam, for your kind words.
Thank you. And the last talk would be by Dr. Sudarshana Skanda. Dr. Sudarshana Skanda is a pediatrician working at Geetanjali Medical Center from Trichy. She was the former secretary of the Indian Academy of Pediatrics from Trichy. Currently, she is the IAP South Zone EB member. She is a member of the Indian Council Against Child Abuse and Child Neglect. And therefore, she is the apt person to talk to us today on child abuse, a wake-up call for pediatricians. Over to Dr. Sudarshana.
Thank you very much, ma'am. Am I audible, ma'am?
Yes.
Am I audible?
Yes,
okay,
doctor.
Okay, ma'am. My thanks to Thangavelu sir for giving me an opportunity. This is a much needed topic that should reach several platforms. My heartfelt thanks to Dr. Dr. Sunil Srinivasan. He was a person who directed me towards the first training program for child sexual abuse. So that was where this journey took off. The presentation, I had the two logos in the first page. One is Indian Academy of Pediatrics, our home, and the other is ICANCIL, Indian Council Against Child Abuse, Child Neglect and Child Labor. It is with the knowledge that I have gained from ICANCIL that I am able to share a little bit of information here. So what is the connection between pediatricians and child safety? Most of us assume that the children who are brought to us are safe. We worry about their growth parameters and vaccination and infections. So, but it's time to realize that there is a connection between pediatricians and child safety, and not all children are actually safe. In 1974, the country said that.
Dr. Sudeshna, I think your internet connection is unstable. We don't hear you continuously.
Children are the nation.
Dr. Sudeshna, please check your net connection, because we are not able to hear you.
Extremely important asset, and every child is an Indian. Am I audible now, ma'am?
Yeah, now I think it's okay.
Sudarshana, one request. If you have hotspot in your phone,
sir.
Please switch on that. That will help. That will act as a buffer. Switch on your hotspot and speak. In case of any Wi-Fi failure, that will come for help. Thank you.
Okay, sir. Am I audible now, sir?
Yes, doctor.
Yes, you can proceed.
So we should remember that the best interest of the child is a primary concern for all pediatricians. So this was about the 2011 census. 34% of Indian children are under the age of 14 years. So we have the world's largest child population. Suppose I say 1% of Indian children are being abused. What is the number? The number is staggering. There was a study on child abuse in India in 2007 by the Ministry of Women and Child Development. The report released is shocking. 53% of children have faced one or more form of child sexual abuse. Children on the street, at work, or children in institutional care are most exposed to abuse. 50% of abusers are persons known to the child or are in a position of trust and responsibility. That is the most dangerous factor. And most children did not report the matter to anyone. So for every child who comes, who's reported, there are probably thousands out there who are suffering in silence. Is a group of physicians who act as regional experts in child sexual abuse. They have undergone training and they are sharing knowledge all over the country. So I attended the program thanks to Sunil sir in 2018. So these are the members from different states. 2019, more members have attended. So we have members from Tamil Nadu as well. As pediatricians, we are in a unique position. Why? Because we are going to see the child from the newborn period. So for children who we see regularly, we know their basic development, we know their emotion, or we know the relationship in the family, and we have gained their trust. So any issue, they're going to come to us first. And there is a high possibility of complete disclosure, and the child is going to be with us for a long period of follow-up. So we are in a best position to do what is best for the child. So what are the physical consequences for a child who has been abused? They can come with severe abdominal pain. They can come with burning micturition. The history of abuse may not be there. You may pick up an unwanted pregnancy. There may be miscarriage of an existing fetus, childhood present with vaginal discharge because of a sexually transmitted disease. There could be mutilated genitalia, which for child can come with some bizarre excuse. And you know that no trauma can, accidental trauma can cause that kind of injury to the genitalia. Or self-mutilation in older children as a result of psychological trauma. What are the short-term psychological effects in a sexually abused child? The child is usually silent because the child feels responsible for what has happened. The child is made to feel dirty or guilty, and the child is told that this is happening to you only because of you. Or the child is threatened. If you go and tell somebody, I will do this to you. Or in chronic abuse, the child is with a trusted person. When he is the abuser, the child is made to believe that this is a normal relationship. So child does not even come out and report. So in acute cases, there is fear and shock. There may be physical and emotional pain, intense self-disgust and powerlessness. Because the child feels nobody is going to believe me. People will say it was your mistake that you went there. The child feels worthless. There is apathy. There is denial. The child goes into withdrawal. So many times we see children whose school performance suddenly comes down. We do not look into this factor that the child is facing abuse in some quarter and an inability to function normally in their daily lives. What are the long-term psychological effects if this is missed? If the child is chronically abused, the child goes in for depression, anxiety, feelings of vulnerability. The child may start assuming that this is how she is expected to behave when she meets a member of the opposite gender. So it is going to affect her lifelong. It makes her vulnerable. There's loss of self-esteem. She can have nightmares. There is mistrust and post-traumatic stress. So as pediatricians, we should be aware that child sexual abuse exists in the community. அந்த முதல் அந்த ஆமா இந்த பிரச்சனை இருக்கு அப்படின்னு நம்ம அக்செப்ட் பண்ணிக்கிட்டாலே நம்ம டெங்கி ஷாக்குக்கும் செப்டிக் ஷாக்குக்கும் கொடுக்கிற அதே இம்பார்ட்டன்ஸ் we will give to an abused child. When we assume that the children are safe, ignorance is the biggest deterrent to our helping the children. We should know that no child is completely free of the risk of being abused. Even a doctor's child has been abused. So this can happen to anybody. It's not just girl children. Boys are also highly vulnerable. They can also be abused. We as pediatricians, we can take measures. We can create awareness in the society by reaching out to, by giving pamphlets, by having information leaflets in the clinic, in the waiting area. And we should remember that any suspicion that is raised by a parent or a teacher or an attender must be given our full attention and must not be pushed aside. So a criminal procedure code section 164 says that in a case of a sexual violence, what is a healthcare worker supposed to do? Examination of a case of rape should be conducted by a registered medical practitioner employed in a hospital, could be in a government hospital, could be in a local hospital, or by any other registered medical practitioner. So when I see, I cannot say, no, sexual abuse, government hospital, GH doctor dhaan paapanga, na paaka maate. No, we should not be saying that. And examination should be conducted without delay, and we should have a complete report. The 3 copies of the report should be ready. Should remember that a criminal law amendment in 2013 of this 357 criminal penal code says that both private and public health professionals are obligated to provide treatment to a child who has been sexually abused. How do we approach the child? First is we have to gain the child's trust. The child is going to be extremely uncomfortable. So we trust the child. We be sympathetic. We are not judgmental. We should tell the child, look, something wrong has been done to you. It is not your fault. You are a great kid and you are safe here. And there is absolute privacy. And what you tell me, I will not tell certain people if you don't want me to tell. It is your secret is safe with me. The confidentiality, that trust we have to gain from the child, and we should constantly reassure the child that what happened to the child is not his or her fault. Remember that children may be accompanied by the abuser. If suppose an uncle is coming and he is the abuser, and the mother brings the child for some complaint, say dysuria, and the uncle has also come along with the child is not going to open up to you. But when you examine the child and you feel that things don't fit in properly, it is fairly easy for us to tell the person who has come along. You can just tell him, you can give him a small slip and say, please fill this form in the registration counter. Please share your contact details or go get this paracetamol and ointment and come. You can send them out for a brief while and then catch that moment to be with the child and with the mother. And in those situations where the child is accompanied by a person with whom the child is not comfortable, the head of the institution should appoint a female member from the institution to be present during the examination of the child. And the choice of this person should be a handwritten letter that is preserved. What about consent of the child? When we give vaccination, we inform the child, ஊசி போட போறேன், கொஞ்சம் லேசா வலிக்கும், ஆடாம உட்கார்ந்துக்கோ. But what about approaching a child who has been sexually abused or where there is a history of abuse? Whose consent do we take? If the child is under 12 years of age, we get consent from the parent or the guardian and we make the child comfortable. But legally, if the child is age 12 years and above, we have to get consent from the child. So it should be a voluntary written consent of the child, and the child at any point during examination, child has the right to withdraw the consent. So we cannot force. So when we examine the examination hall, they should be least disturbing. Examination should be painless to the child, and we should tell, if you are feeling uncomfortable, tell me at any moment, I will stop, and ensure privacy. And you remember that the child has the right to stop you from examining further at any point during your examination with the child. So what about medical examination? Do we say that you go file a complaint and come? Only then we will examine the child? No. You have to examine the child even before a complaint or an FIR is registered. Any registered medical practitioner can do this. We just have to get trained and oriented. Remember, consent is very important. Get a written consent either from the parent or the guardian. The child is under 12 years of age, or from the child herself or himself. Somebody has to be present in the room when the child is being examined. It should be a person that the child is trusting and the child is comfortable with. Otherwise, we nominate a woman from our own institution. And we have to form, there is a complete report. So now, Ministry of Family and Health Welfare has come out with guidelines. The forms are also available online. So we have to fill up the form. The history and examination findings have to be documented. And we have to have 3 copies of the form. One form we keep with us, 1 copy we give to the family, and the 3rd copy goes to the legal system. What is mandatory reporting? I have been seeing a child from the newborn period. The family is very close to me. All the children in the family come to me for vaccination. Now one 13-year-old girl has been brought with somebody has misbehaved with the child, and they want to know, can you please do checkup and make sure that the child is okay? Do you think we should change the school? Those are the concerns that the family is coming with, and they are saying that, look, we are a very high-profile family. We know you so well. This news cannot come out anywhere. Our entire reputation will be damaged. We know who has done. We will keep the child safe. Please don't tell anybody. What is important to the pediatrician is, of course, the welfare of the child. And we should never think that, yes, the family has given assurance that the child will not be exposed to the perpetrator anymore. So they will change the city, they will change the school, and this matter will be kept secret and child will be fine. He will just follow up the child. No. Even in the absence of consent of the child or the parent, we have to mandatorily report what we have heard or seen to the local police station or to the special juvenile police officer. You do not have to have clear-cut proof, but when you suspect abuse, even for the merest suspicion, you have to report. But there is no, according to POCSO, there is no clear-cut rule saying that you have to report within 7 days or within 1 month. That period is not there, but our documentation should be pakka, and we should have at least started the process of reporting. So we should tell the family, look, you have come to me. Legally, I am bound to report this, but we will keep this under wraps. We will take it forth in a way that your privacy is protected. And by not following mandatory reporting, we can face imprisonment for up to 6 months with or without fine. POCSO, Prevention of Child Sexual Offences, is one of the strongest laws of the land. And the child's welfare comes highest in this. So if we miss reporting mandatorily, we could land up in jail. So we should remember that there is something called a forensic kit. So once we get trained, we can have the forensic kit in our hospital where we collect various samples. That is why we have to do examination immediately to collect forensic samples, say a vaginal swab or a cheek swab. And the sample collection is important, including clothes. If you're going to take a sperm sample, if some secretions are dried, some hair is stuck on the dress, we should take their dress also. What is one-stop center? One-stop center is the guidelines have been given by the Ministry of Women and Child Welfare, by the Government of India. The details are available online. One-stop center is created by the government. Private hospitals can also set up their own centers. Any woman or a child under 18 years of age who faces abuse or violence is given shelter in the one-stop center, where everything from history taking to examination to treatment of STDs or other issues to legal aid is being provided. So this is one place where the person is absolutely safe. There are multiple one-stop centers in North India. My search for a one-stop center in South India met with a dead end in Tamil Nadu. We do not have, at least we have like CMC Vellore, they do a lot of phenomenal work, but as far as our government institutions and private hospitals are concerned, Dr. Satish was saying that Apollo Chennai Hospital has formulated a protocol for their hospital. I think the rest of us have to follow suit. Every district should have one government setup and one private setup, and we all have to get trained. And remember, when I inquired about what happens to a sexually abused person, not even a child, a sexually abused person or a child in a government hospital, the pediatrician told me, Madam, naanga andha mari case la paakradhe kadayadu, gynecologist dhaan full paathukranga. So there is no, imagine a child being handled and the pediatrician having no role. So we are the ones who are trained about how to approach a child with empathy. So we need to involve the pediatrician, pediatric surgeon, gynecologist, and a child psychiatrist. A child, according to POCSO, should not be made to relive the trauma every time she narrates. If in my OP, if I see a child and then I say there is some injury to the genitalia, I will send you to the pediatric surgeon. His hospital is the next street. He sees and then he sends a child to a psychiatrist next. So 3 or 4 times, the family and the child have to narrate the history. Imagine the trauma that the child is going to go through. By having a one-stop center, one-time history taking is enough and documentation. Subsequently, everybody else comes and does their job. The child is not made to relive the trauma repeatedly. That is the ultimate aim of a one-stop center. Tamil Nadu should have multiple one-stop centers. So this is available online. Implementation guidelines for state governments and union territory administration. One-stop center. This has been given out by the government of India. It's called Saki One-Stop Center. So what area is required? What is the infrastructure? Everything is available online for us to go ahead and have. So this is a small protocol. When we respond to sexual abuse, remember that the child may be one of the multiple victims of the perpetrator. By bringing out one child and by identifying the perpetrator, we are saving several other children in the present and future victims also. And remember, this was one thing I learned, that if a 14-year-old boy is abusing a 9-year-old girl, the 14-year-old boy is not looked upon as a perpetrator. Remember that he also could have been abused. He also may be a victim of abuse and he's merely passing on this behavior to the next child. So he also needs treatment. So this is what I'm telling is just a tip of the iceberg. I am also learning small things here. We have mentors who are there to guide us in every step. So we have to screen, and if it is look if the sexual abuse assault is life-threatening, and see if the child is safe at home. Remember that we have child welfare committee and district child protection unit in every district. We have to find out their numbers. We have to find out the regional juvenile police officers number and have them in the clinic. Our local IAPs should have a booklet of all these people that we have to contact. 1098 is child line. If the child is not safe in his or her own house, we have to inform child line. They will come and take care of the safety of the child. We also have to monitor long term. Our aim is not to make sure that the perpetrator goes to jail. We are not here on a fact-finding mission. We are not like a national news channel. We should not share what we see on any of the WhatsApp groups of our pediatric groups. Matter must be kept extremely confidential. Our aim is to do what is right for the child. First is safety of the child, separation of the child from the position of danger, examination of the child, documenting. Remember that in an abused child, clinical examination findings may be nil. An abused child examination from head to toe completely normal. So at the end of examination, is everything is NAD, no abnormality detected. We do not say no features of child sexual abuse. We should never come out with that. We should be aware that an abused child can have completely normal physical findings. So keeping that in mind, our aim should be first is safety of the child. Second is documenting complete. We do justice for the child simply by documenting properly. And then by involving other specialists. And then long-term follow-up of the child for therapy. The child should know that this is not normal and it is not his or her fault. And the child should be able to lead a normal life long-term. So we should have a long-term follow-up of these children. This book is available on Amazon. I checked just now. If you order now, it reaches us. The Kindle version is also available. This book is a powerhouse of information. Much is needed for us to, there's so much information given by the mentors in this book. So thank you very much for the opportunity. I sincerely thank IAP TNSC for bringing up a topic of child sexual abuse. And I hope we have many more such sessions where all of us can learn together. Thank you very much.
Thank you, Dr. Sudarshana. I think you have finished ahead of time. You provided 25 minutes. You've done it even within 18 to 20 minutes. And so we have good time for the question and answer. That was a very excellent talk, Dr. Sudarshana. We learned a lot from you about the child abuse and child neglect. It's a real wake-up call for us. And every symptom that you have told, I think we have to keep it in the differential diagnosis whenever things are suspicious. And you say as you say, no child is safe. The world is now like that. It was there earlier. It is much more now. And therefore, in many of the conditions, we have to keep child abuse. I think as pediatricians, we should not be only concerned about nutrition, immunization, wellness. I think wellness also includes that the child is also safe. So that's very, very important. And as you say, probably giving a little booklets or keeping them in the thing, at least we create a parent's awareness regarding all these things. That was an excellent talk, Dr. Sudeshna. Thank you very much. Can you stop sharing? Now we would have the Q&A session. This is one comment from Dr. Lakshmi Venugopalan, who has said that family planning surgery should be done after 45 days. Any particular comment from any of the speakers?
Okay. And Dr. Nandini, she is also told that because IEM, I think this Professor Lakshmi Velmurugan from ICH, she is also told that extended her comment saying that IEM and congenital heart diseases cannot be diagnosed at day one. So we have to wait for at least some more time, at least 45 days. It is only a pressure from the family to the obstetrician and obstetrician to the pediatrician.
And if at all the obstetrician is asking the pediatrician, can we go about with the thing? Can we write out, like if the pediatrician can see baby looks well, however, inborn errors of metabolism and some of the congenital cannot be said yes, no at present. Are we to write like that? Probably Dr. Thangamuthu could tell us, or any of the other experts could tell us, how do we go about in documentation in such a situation? Because the call is there, it's a Caesar or it's a labor, so there's no time. So you examine the child. So do we ask them, no, you should do interval sterilization? What if the family wants a puerperal sterilization then? How do we go about, sir? Experts opinion.
Government hospital, we used to do several puerperal sterilization on the third day. So far, we didn't come across any of these kind of cases. So even after getting this kind of cases, we have to wait for some more days. Congenital heart diseases, 7 days, we will be able to find out by referring to the cardiologist and other persons. So we have to wait and do the necessary investigations. Then we can go for PS. That is a correct thing. We cannot postpone the case for 45 days. Then uterus will go down and the surgery will be very difficult. So we can do puerperal sterilization with waiting for 7 days and getting a cardiologist opinion. Thereby we can escape and we can do it. We did several cases in GH. No case we didn't come across like this. It's only a special few of the cases we come across like this.
Sir, any other opinion from any of the other doctors?
Yeah, actually, what Dr. Thangamuthu sir said, actually, it's very difficult to pick up IEM and as well as congenital heart disease, cyanotic heart disease, suppose follow in within 7 days. I think better to document it. If you are having a clear cut, you want to make a safeguard yourself. I think no obvious congenital anomalies made out. I think better to document these things, and you can have. I think for format, we have to make it on format. If that pediatrician format needs the typed format and need a routine protocol also. I think Dr. Sadish, I think, want to tell something. Yeah, please.
Yeah, sir. Actually, there is a practice called cesarean sterilization, where the practice of doing the sterilization after cesarean at the same time. And so the pediatrician is asked to certify whether the baby is okay. You have to just examine the baby on the table and you have to certify. But there were instances where the anomaly scan could not be done or was not done in an unbooked case. So cesarean sterilization happens, and the parents insist that they wanted to get the sterilization done because they would not want another admission and another operation. So what should we do? Because actually there was one case which has come up in one of my friends' practice, that it was a congenital heart disease, as Dr. Rajendran said, that could not be made out on the resuscitation table after just a cesarean newborn within few minutes. The doctor has examined and then went through the antenatal records, and he has certified that the baby is okay and go ahead with the cesarean sterilization. But he came out and told everything to the baby's father, parents. The mother was already under anesthesia. Then he told, but it was an oral statement, but it was not recorded, and everyone nodded. And finally, by about the 5th or 6th month, it was found to be a large VST. Fortunately for the baby, had an intracardiac repair after that the child recovered. But they sent a letter saying that if the doctor had probably examined and then he was certified that he would wait, we would have waited. We would not have insisted. Then the doctor had his own defense that congenital heart diseases could not be diagnosed at the delivery table, and it was insisted upon by them. But with the good office of the obstetrician, they said that the people were silenced because there was no time for the pediatrician to get the rapport. And obstetrician said it is what the doctor has told is correct, and therefore he can't hold the doctor responsible for this. And it's definitely a problem in certifying for cesarean sterilization.
Very good, sir. Very good. Correct, sir. As you said, we have to get it in writing regarding not doing the investigation because of they are insisting for PS on the table itself. We have to get it in writing and then we proceed with the surgery. I think that is a correct thing.
Yes, sir.
Subramaniam, sir. Yeah. Sir,
we have Dr. Dr. Balaji wants to know, like some of the insurance companies. Subramaniam sir wants to, yeah, please. Please, Dr. Subramaniam, your insight into this.
With that is just a US, my daughter, where she is, pretty well. That is, she wanted to have people sterilization, where they said you must have given the consent or requisition in the antenatal period, where with all the antenatal investigations and giving a disclaimer, this is possible to know only on this month, that month, etc. A big thing. Are you agreeable to all these diseases which may come, which is not detectable within 48 or 72 hours? If all the concerns are given, then only they attempt it. So we here, the government institutions, they do it, they don't get, that's a different thing. But we in private, there are lawyers to say, we will sue. And your practice, when you get a lawyer notice, you are afraid of 3 or 4 persons. One is income tax, one is constable, the other is consumer court, etc. So when it comes, you jump to conclusions and then you fail a lot. Please do not jump to puerperal sterilization if it is an unbooked case, if the precious child, bad obstetric history, with so many things, keep your fingers crossed, or else have a disclaimer of all the diseases which are likely to crop up at this month, at this month, at this month. So you are asking me to do it within 48 hours. This is the thing. Better be safe on practice.
Thank you, Dr. Subramaniam. Sir, Dr. Balaji wants to know, many insurance companies are asking for the case sheet and doctor's degree certificate. Should they have the rights to ask, shall we give it to them?
Please, let me tell, that is as far as insurance company is concerned, if it is a cashless hospitalization, for them to come to a correct conclusion, they need case sheet. For which case, there must be an MOU. Suppose this hospital and this insurance are going for cashless. You have to give me who are all the doctors, their certificates, and then your this thing, what do you call how much this is chargeable, all these things. This much we will do. But case sheet getting and the transparency of the patient's particulars unavoidable. But at the same time, should the patient suffer from AIDS and you have given that AIDS to that insurance, the patient will file a suit against you. What to do? First of all, blanket statement, as I told in the slide, I have no objection in sharing all my case sheet details with the insurance, etc. On day one, you get the signature, you are safe from the patient and you have obliged the insurance and cashless happens.
Thank you, Dr. Subramaniam. And this is another question. Can a patient who has got an IV in the hospital be sent home with the IV to have some intravenous medications as outpatient? From Dr. Nedunchelian.
Yes, that and all I have replied directly to them after seeing that. That is leaving a patient, for instance, what I suffered, this consumer charging, etc., discharged a patient with a very, very bad history, obstetric history of 4 children lost, 5th child admitted in my nursing home, and it was 1.5 kg or something like that. With Venflon we have put, but they couldn't in 1995. We charged 5,000 rupees on day one. She said, I cannot afford to, you refer me to GH. We did it with this Venflon, because Venflon cannot be reinserted 1.5 kilo. And when we send, it can be kept for the 36 or 48 hours, that's something. So we sent it within 24 hours. But unfortunately in GH, they kept it for 15 days and the child developed a gangrene or something. At the 4th month, the child amputation was done, and a lawyer and the patient, they stood against us, and it came to the court in Tirunelveli. It was declared against us, but we appealed in the High Court. It took for 5 years. Meanwhile, the child got admitted over 5 to 7 times in Madurai Medical College, declared as immunodeficiency and died. But what the judge said, why did you allow? Then we told all these reasons. The appeal, the High Court judge, he accepted it and left us scot-free. But the agony was with us for 5 years. One. Number 2, in Kaveri, what Dr. Manivannan, who is expert everything, whenever you are discharging a patient with the tube or oxygen, send a doctor, go to the house, hand it over to the other doctor who is going to maintain, family physician. If you have got a chain of medical people involved in it, you are safe. Otherwise, I am giving it to a non-medical person. If he allows air, 20 cc's of air is enough in an IV. And in the oxygen, empty cylinder, he is going to give that. That cannot. All these things, the parent doctor only gets all the things. So this is a risk. Depending on your relationship with the patient, do it unofficially. If you ask me by writing, don't do it.
Thank you. Thank you, Dr. Subramaniam, for that very practical answer. One more question from Dr. Nedunchelian. Any need of oral assent of a child under 12 years along with the consent of the parents or the caretakers in the case of a suspected or a confirmed child assault or abuse? Dr. Sudarshana, maybe you could take it up. Dr. Sudarshana?
Unmute Sudarshana.
Yes, ma'am. Could you just get me the question again, ma'am?
Any Dr. Nedunchelian wants to know any need of an oral assent of a child, because only after 12 years we take a written consent from a child. So under 12 years, any need, because it is the parent or the guardian. So any need of an oral assent of the child also under 12 years, along with the consent of the parents or the caretakers in the case of a suspected or a confirmed child assault or abuse.
Ma'am, we approach from 2 points of view. One is legal consent. So legally, we have to get consent from the parent or the guardian for a child who's under 12 years of age, and we get the guardian's written consent. A child 12 years or older, we get the written consent of the child. But a child who is younger than 12 years, like any other pediatric examination, after getting consent from the elders, you're going to make the child feel comfortable and then go ahead and examine.
So it is only an oral assent.
Yes.
So just we are going to make her comfortable and then go about the examination.
Yes, ma'am.
Sir, Dr. Thangavelu, sir, any other questions that you have
madam,
seen?
One small query, madam.
Okay.
I am Dr. Ramesh Babu speaking.
Okay, sir.
I want to get clarified of my personal experience.
Okay, sir.
A male baby delivered in a government hospital. The parents took away the baby after discharge. After 2 weeks of life, on the 15th or 16th day, they bring the child to the same government hospital for vomiting and some abdominal distension. The pediatrician sees there and does an ultrasound and finds it is to be an infantile pyloric stenosis. He tells the diagnosis to the parents. the parents say that they don't want the child and they leave the child and go away. It's a Taluk hospital. The pediatrician there calls me to my institution. He calls me and says that such a baby has been abandoned by parents, and I am going to refer the baby to you to proceed further. And in another 2 hours, I received the baby. Unfortunately, the doctor there didn't make any AR entry. So first thing we did was we did an AR entry and informed the police personnel and also informed the referral institution that because that they given the parents' address, the parents' name, phone number, and all they have given. But when we tried to contact the parents, no one picked up the phone. So we gave the complaint to the
Dr. Ramesh Babu, you're disconnected. We don't hear you anymore.
We are not able to hear.
Dr. Nandini, doctor,
yes.
Regarding such abandoned cases, you have got, since I was the doctor for orphanage for 8 years, that is whenever a baby by total titam or any other thing abandoned with the knowledge of the one police and with the knowledge of the district social welfare board, the local, the child help organization, they take it. And they wait for 2 years or 1.5, something like that. And then it is set for now the adoption, legal adoption, etc. when it is abandoned. But they keep it for 6 months for them to come and claim. After that, they say this is a child only for the adopted mother and father. They give the initial and all legal things, etc.
No, but this is a child who's abandoned but had to undergo a procedure. That's what.
That also the social welfare board will take care of it. Okay. No doctor can do it. We cannot take it.
I think we cannot transfer from one hospital to another.
Subramanian sir, I want one doubt regarding that Ramesh Babu case. What he has told, suppose they're going for surgery, who has to sign for that consent?
Again, social welfare board, they will be the foster parent. The district collector is the foster parent of abandoned children.
So district collector has to sign.
Not saying social welfare.
That means we have to inform the police.
Samuga Nalathurai, or even not even police, Samuga Nalathurai, the Tahsildar, they will say, but the operation cannot happen in your nursing home. They will choose which is the thing when government, if the government is available, they will go to the government only.
Okay, that means that the Samuga Nalathurai, they have to sign somebody for the Samuga Nalathurai.
They will take care. They will. Once you intimate, either they may ask you to do if you are the only doctor in the whole of the district, or they will bring it under CM scheme, and any politician will come and claim good credit by doing it free or something. But we should not do it without asking anybody. We should not burn our fingers.
At the same time, treatment should not be delayed also. That is also important.
Yeah.
For want of procedures, we can't delay too much. Probably, we can involve senior teachers or even collector, he said. Somebody will discuss.
Collector will be the better person
because he will take all the responsibility. Maybe in a written form as well as by telephonic form.
If it is an emergency, it's Friday night, Saturday, collector, nobody is there. 2 or 3 doctors, if there is a team who says it must be done, when finance is not a big issue, you can do it and then justify it. You cannot do it alone. Single doctor should not be there.
Dr. Jalil has raised your hand. You can.
Good evening, Dr. Nandini. Good evening, Rajendran. Fantastic deliberation today. Very useful. I just wanted to know what is the meaning or recommendation for implied consent. We always get an informed consent. Is there any specified form for that implied consent?
Consent. Actually, I already discussed during my talk about immunization. So when a particular facility, when the patient is approaching suppose for example, he's coming to get a wound getting treated by you. You are a surgeon, they come to get the treatment by you. That's actually he has chosen to come to your clinic, chosen you as his doctor, and there's an implied consent in it. And you can do the emergency after of course, if it is going to be an immunization, there's a dilemma. The ACVIP experts have said that the parent approaching to the doctor and bringing the child for immunization is itself a consent. He has chosen to come to you. So that's implied consent. The informed consent is the doctor explaining everything about the act, its deliberation, its pros, its cons, and what is the adverse reaction, what do you have the machinery for adverse reactions, any fatality that could happen, all with that information has to be given, that must be communicated. It has to be communicated in the native language of the patient and parent, and signature has to be obtained that he has understood everything, and that is informed consent.
Sir, do we need to document the implied consent in our case sheet or in the OPPA?
There's no need. Implied is implied. There's no need to write anything. So that
we see when we come for vaccination, sir, we write there is come for vaccination or immunization.
Yeah.
That itself is thing, and then you write the well
that too was not accepted in the medical legal group.
In the court of law.
No, one doctor, medical forum of IAP has said that is not adequate, and he has also given a medical legal forum of IAP has given a prescribed format for the vaccination consent, which there are so many clauses in it, and I think a briefer form has to be designed by us.
One good information, sir, because regarding the neonatal screening, before the baby getting discharged from any birthing hospital, all the 5 screening has to be mandatory, including the critical heart screening on the 3rd day. It is mandatory, sir.
Yes, sir.
But Nandini, can some more questions are there?
Yes, sir. Yes, sir. Sir, you can put up.
One is from again Dr. Nadinjayan. He asked very basic question. Is it correct to consider the doctors simply as providers and patients as consumers and bring under consumer forum? This was already explained by Dr. Thangamuthu, sir. Can you please explain, sir?
Already, as per Supreme Court Order 1996, doctors under consumer forum was brought in by Supreme Court. But latest 2019, already in Parliament, the act was passed that from consumer forum, healthcare is removed, and in both the houses already the act was passed. We are waiting to get a government order regarding the same. For 2 years, we are fighting with the central government. We approached the health minister several times. They all asked to wait, don't go to court. Wait for some time, we will be issuing an order regarding the act. If the act comes into force, then the healthcare will be removed from consumer and will be free from consumer. That is the status now. Okay. Now we come under consumer. There is no any doubt. Excuse me, sir.
Okay, sir. Sir, we have Dr. Sue Karthi, who wants to know the responsibility of a pediatrician in transporting a sick newborn in ambulance. Doctor, any one of them can take it up, sir. Dr. Satish, Dr. Subramaniam.
Madam, the transport ambulance, I think there's a protocol that Dr. Subramanian has dutifully put it as an ambulance extended arm of the tertiary care hospital. And therefore, there has to be a communication from the referring hospital to the referral hospital that there's a need to transport and there must be consent. It cannot be just like that, go to the doorstep of the other hospital. The particularly needing ventilation, the ventilator has to be available. It should be free to be given to this patient. After proper communication, a team has to come from the tertiary care hospital to the referring hospital, and the doctor already apprises of the referring hospital to the tertiary care hospital about the patient status. And depending on such a thing that who is going to come to pick up, the pickup person must be adequate enough to intubate, ventilate, to give some in transport care, and transport ventilator, transport incubator, everything has to be provided there. It should be available. And after going to the referral hospital, that is tertiary care hospital, only then the responsibility of the first hospital ends. And it is until then, the first hospital is responsible until the patient reaches the second hospital safely. Actually, there were instances where a death has happened in the transit, and therefore the tertiary care hospital did not give the death certificate, and the first doctor did not accompany, and it's only the nurse, paramedical people from the first hospital went with a letter, and actually that went to the court. I'm not aware of what has happened after that. And what is the position in law? I think Dr. Thangamuthu sir may throw light if such a thing happens.
It's a very good question. Whenever we refer the case to the higher institute, we have to send a referral letter along with copy of the case sheet. That is a must. Several of the cases, we are giving only referral letter. We are not giving the past treatment given in our hospital. That is wrong. Then, while going in the ambulance, the doctor must accompany along with the case. That is also a must. And death on the way, if it occurs within the territory of the referring doctor, the duty of the referring doctor, he has to give the death intimation to the particular panchayat where the death occurs. That panchayat, he has to intimate. That responsibility lies only on the referring doctor, not the receiving end. That is a very important thing. That is the rule says. See, in one case, patient died on the way and the body brought back to the hospital. Doctor gave a referral, that is intimation to the local authority that death occurred only in the hospital. That gone to the court, and the judge says, how can you say death occurred outside as death in your hospital? That is a negligence on the part of the doctor. So, for statistical purposes, we have to intimate the panchayat where the death occurred. That is a very important. If I refer the case to the Coimbatore, if the death occurred on the way, I have to intimate to the particular panchayat where the death occurred, not at Pollachi or not at Coimbatore. And the duty lies on the doctor who refer the case to the higher center. That is a thing. It is a very important matter. We have to remember it whenever we are referring the case. And without case sheet, don't refer the case. There are several cases. They are asking why you didn't refer the case along with the treatment already given or case sheet copy. That is a very important thing. And the doctor has to accompany the case till the body is the patient is handed out to the higher center.
Thank you, sir, for the clear message.
Important message. Excellent enlightenment by Professor Thangamuthu sir. As he said, everything I agree on that. But the thing is, as he said, even birth that happens from Chennai to, if it happens in the mid-year at Germany, Germany has to give the birth certificate. That is the same thing. But one important thing I would like to do, everybody, the doctor, when they refer the case, okay, take it Apollo, Mia, something at Chennai, when they give it, then the doctor comes out. No, you have to get it in the pro forma. What is the pulse? What is the thing? That it is, etc. Because if anything happens, they may say, we received the case in this bad condition, which the ambulance doctor may not have. No, we gave it in good condition. They are writing a different notes, nothing doing. You just land there, get the receipt, just like you would pay electric bill, get a receipt. If you are handed over the child, in what condition you have to get it. Then only if any case comes, both the hospitals can act synchronously.
Madam, I think Dr. Thangamelu sir actually wants to present 1 or 2 slides. Dr. Thangamelu sir.
Yeah. I think
I'm in the line. In the meantime, if we have time, some more questions are there, sir. Are you able to hear me, Nandini?
Dr.
Video.
Karthi also wanted to know about the video teleconsultation, which Dr. Satish had said. But I think that there are those criteria for teleconsultation, sir. I think you put up a slide. Dr. Satish?
Yeah, madam.
So the Dr. Karthik wants to know something about the teleconsultation. I think you had detailedly put up with all the things. I think it should have the signature and finally with the signature and the everything.
I think we can share in a group, madam.
Yeah, we can even share. I think.
No, I can just tell without the slide also, madam.
Okay, without you can just say.
Yeah. See, first there has to be a service provider in telemedicine. Doing it WhatsApp is not a guarantee and is not a good way. There has to be a proper contract with the service provider. There must be the telemedicine platform has to be given by a service provider with an IT backup. The doctor and the patient are connected by the service provider. There will be a prior sharing of the case history of the patient to the doctor even before the consultation begins. The doctor is apprised and be aware of what the patient condition is and what the patient wants. Then if any reports are there, they are also shared in the video chat. Then even after the consult, it's a video consultation where it has got its own limitation. For example, if some patient, the parent complains saying that a 6-year-old boy complains of abdominal pain, it is difficult to really, you have to palpate the abdomen, and therefore what is to be done is make the patient stand, make the patient lie down, make the mother touch periumbilical region, each quadrant of the abdomen, press and see the child winces. And after all that, you have to record all these findings and say there are limitations in the examination, and you can order for investigations and ask them to share with you in the same evening. Or you can even say that I cannot do it if there is something ambiguity, something where you are not sure. If it is, then you can say that you have to go for a physical consultation in the nearby hospital or a physical consultation to me. It's always a good way of ending the teleconsultation is, please come and meet me or any other doctor near you if the symptoms are not getting abated within 24 hours, or if anything other than what you told is happening to the child. And so that will be really, and we'll be exonerating ourselves from various problems, because it could be as appendicitis, it could be some acute abdominal condition which you can't say. Then the telemedicine should have the digital signature. And also review consultation, if you want, you can always mention. If the review, two things have to be done. Come for a physical consultation to me or to someone nearby you if the problem doesn't get solved. Second thing is the review is needed. So when they fail to come for review, it is actually contributing negligence on their part, and therefore we are not responsible for anything happens to the child. And so that much of protection we must have for ourselves when you do a teleconsultation.
In short, I think better to have a first consultation, better to be physical. It is safer for both patient as well as for the clinician, I think. Maybe very useful for review, particularly specialist review. First consultation is maybe safer because there is no scarcity of doctors. Somebody calling from Trichy, they can consult there. Some pediatrician in Trichy itself.
You're muted, sir. Muted, sir.
Excuse me, madam.
Unmute panning, sir.
Excuse me, madam.
Yes, sir. Yes, sir, please.
Regarding telecommunication, there are so many judgments. You cannot treat the case without seeing the case. If you give treatment through the phone or telecommunication, that is not allowed by the court. Only after Corona, the emergency rule came. Since there is no any communication, there is no any transport facilities. During that time only, they accepted telecommunication and telephonic instruction regarding the disease and other things. If we follow even after Corona, I don't think the court will accept. That is an emergency situation. They allowed the telecommunications. Now there is no any restriction. Patient can directly approach the doctor and get his opinion and get a treatment. Without seeing the case, without examining the case, we cannot treat any case in today's situation. That is my opinion. In emergency, they declared, in the Corona period only, they declared telecommunication and telephonic message, you can prescribe medicine only at the time of Corona. Now Corona is over. I don't think court will accept. Without seeing the patient, I have given treatment through telecommunication means court may not accept. That is my opinion.
Okay,
Okay,
sir.
madam?
Okay, sir.
Yes, madam.
Sir, one other, I think we take this as the last
Excuse me,
question.
madam, another clarification I want to tell. Whenever the patient brought dead to your hospital, you cannot certify you cannot give, we have to refer the case to the nearby government hospital for post-mortem. Then only the particular hospital can give death certificate. Without examining the case, we cannot give death certificate, or we cannot give a referral letter, or we can give referral to the death intimation also we cannot give. If you want to give a death intimation, you have to examine the patient, you have to write a cause of the death and other things in the certificate. Without seeing the case, we cannot write it. So the case brought dead in your hospital, we have to refer the case to the government hospital post-mortem. We not to bother about post-mortem. Every case need not be go for post-mortem. Inspector and police people can come, they can get a opinion from the parents and all of the doctors. They want that nothing is any harmful things or nothing, any evil things happen. They can hand over the body with the opinion of the hospital doctor and as well as referring doctor. So that is the rule we are following. We cannot once we receive the dead body, we cannot give a death intimation. We don't have any power to give intimation without giving a diagnosis. Okay. What we are giving to the local bodies is only a death intimation. That is not a death certificate. Certificate will be issued only by the local authorities, municipality, corporation, and other people. We are not eligible to give death certificate. In medical legal cases, the police will intimate to the local authority. From there only they get a death certificate and they will hand over to the parties. That is the procedure. Death intimation we cannot give the case brought to the hospital in a dead condition.
Sir, you just tell me whether what we are doing is correct, sir. When a child is brought dead to the ER, what we do is we do the CPR, make an entry, AR entry, and inform the police and hand over the body to the police, so that generally they take it to a nearby medical college for post-mortem and give a death certificate.
Not necessary, sir. Everybody need not be go for post-mortem.
So who will take the decision, sir?
There is one provision, sir. The police can inquire. They can form a commission. Along a member, a doctor can be a member, and nearby house members also included. They will go for a complete inquiry. There is no any foul play. They can hand over the body. Every body need not go for post-mortem. There is one provision. We are doing only that only. So many bodies are handed over without any post-mortem. But if we give a death intimation, the responsibility will lie on the referring doctor. That is an unnecessary botheration to the doctor. That we have to remember. All body need not be handed over. See, in our Pollachi, there are 2 deaths in the hospital. We send an intimation to the police. They advised to hand over the body. We refused. You take over the body, you form a committee, you declare that there is no any foul play, then you hand over and we will accept. That is the thing we happened in Pollachi in 2 of the cases. Police has got a power.
We hand over to the police, sir. What you are saying
Yes,
is
sir,
we hand over to the police.
We have to hand over the police. Police need not do post-mortem for all the cases. With the history, with the relative's history and doctor's opinion, they can come to conclusion and they can hand over the body without post-mortem. Not necessary to do post-mortem for each and every case. Police has got every right, but we don't have that right. Without seeing the case, we cannot write a cause of death in the referral or in the intimation certificate. Okay.
Sir, even in, if I can say 2 words, even in ICH, we hand over to the police, all brought dead, we examine, and the police decides. It is they who decide. Some of them, they inquire and they hand over the baby or the body to the...
Yes,
but
correct.
some they go.
Correct.
But that onus is on them. Once we automatically, we face problem when the child has traveled from Andhra and come and died on the way. We wait for the Andhra police to come, then hand over, and the onus is on them. Just for what we are doing, sir. Just wanted to.
Yes, sir.
Thank you, Dr. Eliel Alasi. And
Please allow
I
me.
think if there are... Yes.
Hello,
Yes, Dr.
excuse me.
Subramaniam.
Dr. Balaji has asked me a question. That is, there is a word discharge at request. Either discharge proper or discharge AMA. There is no in between discharge at request. Whose request and everything will come as a question later. Don't let not the doctors get into any problem. Okay.
Okay. Thank you. Thank you.
Sir,
If there are no further,
sir.
Yes, sir. Okay.
Yeah.
Yeah, over to, thank you for giving me this opportunity. Over to Dr. Thangavelu, convener. And it was an excellent session. Thank you, sir. And thank you all the speakers for such an excellent session. Over to Dr. Thangavelu.
Do you see my slide?
Yes, sir. Yes, sir.
There are only 2 points just want to add to the exemplary information given by the faculty. Never answer anybody's health status by telephone, even it has come from a big person or VIP or political person. Even when the mother or father is asking you about a child, we are not supposed to tell the health status by telephone. You can politely tell, what we do is politely tell them to come to the ICU and we are ready to explain to you. That is a way. Because we had an incident where the nurse disclosed the pregnancy and she had to commit suicide to protect her. Second is, don't be in a hurry to declare death in hospitalized patients. Wait for at least 20 to 30 minutes after the CPR completed without return of circulation. Because to avoid Lazarus phenomena, that is, baby started moving after death. I got into a problem in a case like this when I was working in another country. So after that, once the child shows asystole, better let the asystole continue for 20 to 30 minutes, then only we can declare death. These are the 2 things I just want to add. Plus, recently I had a WhatsApp message which was very, very nice at this point of time. I don't know the source. Golden word for every doctor. A patient is never a customer or a consumer. Let the law of the land say anything. Every patient is alive with a beating heart and a thinking brain. And that means we are being trusted by the patient to keep that heart beating and brain thinking. That is our responsibility today and after 1,000 years, even after 1,000 years. Let us not be carried over by pride, anger, or suffering, because we are the only link between the patient and life. Every patient will not be kind to us. Some will shout, some may blame, some may threaten, and some may even sue in a court. Stay above all that plane of interaction. Do whatever we must do for the good of that patient. If we feel you are not required, leave without either a harsh word or bad feeling, because more lives wait to be saved by us. Our time is precious. Clinical skills, patient interaction, and communication skills are often sharp decline. We'll all be benefit from learning more about this in the massive information overload that burdens us, not only burdens us and also burdens the family. Clinical skill form a solid ground to confidently walk upon it. The fear of committing a mistake is universal among all of us, among the doctors. Please learn to develop our own individual strategy to overcome that fear. Be the best soul that our patient needs. Even the most illiterate or rural patient will notice our words, manners, and etiquette. These must always be perfect. So enjoy every moment of that holiest path that we have chosen to treat upon the earth. May God keep us protected and happy, and may each one of you save many million lives. I could recollect many times my kith and kin are admitted and saved by many doctors. Not only me, everybody would have experiences. One Naladangal story cannot bring a demoness status to all mothers, because only one Naladangal, she put the babies, throw the baby into the well, and she also committed suicide. We can't blame every mother. So let us not be always legal oriented. Let us continue our good work. At the same time, we'll also learn and practice self-protective measures taught during the CME without compromising healthcare delivery. For example, vaccine administration, we do with a good intention. They come with a card. In the card, everything is written there. We can go ahead with it. If we always think about legal, probably we may not do our work properly. For one in 1 lakh or 1 in 10,000 family who is going to sue us, let us not punish everybody, all the rest of the family. But only thing that we must be able to protect ourselves. So we should have a good documentation, learning from all the clues given by the faculty. Now, that's what I just want to say. This may be an antidote for what we talked over 2 hours, but this is the practice what it is better that we practice that. Thank you for the time, Nandini.
Thank you, sir. Thank you very much.
On behalf of IAP TNSC, I really thank our program convener, Dr. Thangavelu sir, and who is a pioneer and he is planning meticulously to make this medical legal issues feasible. I thank once again to Dr. Thangavelu sir And I thank today's chairperson, Dr. Nandini Kumaran, who has done excellent work and is a well-known person also. Thank you, madam. And I thank our Thangavelu sir, who has spoken on medico-legal issues for pediatrician. And I thank Dr. Subramaniam sir, legal challenges in admin. And I thank Dr. Sadish sir for legal issues in office practice. And I thank Dr. Sudarshana Skanda and child abuse wake-up call for pediatrician. I think it's an excellent program, and I think it is whatever we are knowledge gaining, we have to safeguard ourselves medico-legally. That's very important. And I think it is really wanted and needed program also. I think as Dr. Thangamuthu sir said, I think telemedicine, I think you have to be very careful. I think now post-corona, you have to be very careful. I think all the patients, I think a recent one judgment, I think within 15 days back in Delhi also, same thing what Dr. Thangamuthu sir said. I think now over, I think we have to go for regular consultation. That's very important. I think our doctors also, we have to aware this issue also. And I once again, I thank one and all for this wonderful opportunity for IAP TNSC. Thank you, one and all. Thank you.
Thank you, everyone. Thank you.
Thank you.
Thank you. Thank you, one and all. Thank you, sir.
Thank you, madam. Thank you, madam.
Thank you, sir.
Thank you, sir. Thank you, sir.
Thank you, Dr. Thank you, Dr. Rajendra.
Thank you to all the